but also for your participation in this conference. As we develop and the population grow, the lifestyle has also been impacted by the economic and working conditions, competition, infrastructure, education, culture, and environment. Non-communicable diseases, and you know that the big four are cancers, diabetes, cardiovascular diseases, and chronic respiratory diseases, but there are also many others, including mental disorder diseases and others, and disabilities. They have been globally recognized as a human development challenge, chronic in nature, and the world's leading cause of death, morbidities, and disabilities. NCDs kill 41 million people each year, equivalent to 71% of all deaths globally. Moreover, 15 million of these deaths are premature, between 30 and 69 years old, and mostly they are preventable. Over 85% of these premature deaths occur in low and middle income countries, like Rwanda. And every day, people living with NCDs have to make painful trade-offs, such as cutting back on education for children, selling assets to clear NCD medical bills. Over 60% of people living with NCDs have experienced catastrophic health expenditure, paying for NCDs treatment and care, particularly hitting poor households in a cycle of suffering, impoverishment, and illness, particularly for those who have no medical insurance. But we need to talk about the cost of inaction, because Africa is still facing a double burden of infections and chronic diseases. It is projected that NCDs will overtake infectious diseases as a major source of morbidity and mortality by 2030 if we don't do what is needed to reverse the trend. In 2011, the World Economic Forum projected that NCDs would cause 21 trillion in losses in developing countries over the next 2 decades, a cost quite equivalent to aggregate economic output of these countries in 2015. The cost of continued underinvestment in the fight against NCDs has been estimated at 47 trillion in lost gross domestic product globally from 2011 to 2025. In 2011, heads of states have convened around the world and acknowledged that the global burden of NCDs constitutes one of the major challenges for development in the 21st century, which undermines social and economic development throughout the world. They have recognized the primary role and responsibility of government in responding to the challenges of NCDs and the essential need for the efforts and engagement of all sectors of society to generate effective response for the prevention and control of NCDs. The government of Rwanda has been responding to make NCDs and universal health coverage a high priority in development planning by assuring access to medical care for all, providing leadership and support that brings together all the efforts from different stakeholders. But we need also to say that there is an individual responsibility. Most of the NCD risk factors are modifiable, and each of us has a personal role to play in stopping tobacco use, stopping alcohol consumption, reducing salt intake, sugar intake, eliminating trans fat, and being physically active. Considering the burden of NCDs, we would like to call here for higher levels of awareness and education about NCDs at all levels, more effective multisectoral coordinating mechanism, more efficient data collection, monitoring and evaluation systems, more effective accountability mechanism, and increased financial prioritization of universal health coverage and NCDs. And if we come back to the theme of the conference today, in order to oversee the implementation, the performance and effectiveness of all NCD policies, plans, and programs, we need a multi-level and multi-sectoral coordination mechanism, which could be decentralized and maybe integrated in the conference based on accountability system of IMHIGO. This will progressively improve the enforcement of laws and policies, the follow-up, reporting, research, monitoring and evaluation of programs for evidence-based interventions and planning for UHC and NCDs. I would not like to finish my welcome note without appreciating the support of different partners for this conference to happen. First of all, of course, the Ministry of Health, the Rwanda Biomedical Center, the Global NCDA, Danish NCDA, the Fit NCDs Partnership, Rwanda Diabetes Association, the WIWO Hospital, but also I would like to commend the work of the RNCDA staff and organizing committee for the tireless effort they have invested for this conference to happen. And I would like to thank also all distinguished guests, speakers and moderators, and all participants, physically and remotely. It is my pleasure to call our guest of honor, the Honorable Executive Secretary of Human Resource for Health, for his opening remarks.
Thank you very much, Professor Muchumbitsi. Professor Muchumbitsi, chairperson of the National NCD Alliance, government officials, UN agencies and development partners, head of international NGOs, civil society organizations, and patients groups. Ladies and gentlemen, good morning. On behalf of the Ministry of Health, I would like to express our earnest pleasure to be part of the NCD Conference 2021. It is an honor to welcome you, distinguished participants, on behalf of the hosting institution and organizing committee. This conference is a moment to reflect, strategize, and project on our individuals and institutions' endeavors towards multisectoral approaches for the prevention and control of NCDs in Rwanda. Multisectoral collaboration for non-communicable diseases and universal health coverage is the theme of the conference. It calls for redefining the role of each health and non-health factor, including policymakers, regulatory bodies, interested partners and communities working towards the same objectives and undertaking the necessary changes at their levels. And when we talk about multisectoral approach, we think that this will cover different areas, including health promotion, prevention, curative, rehabilitation, and all the different components of health. It's important to consider that we will not be able to fight NCD only in hospital, because the best prevention, the best cure will be to prevent people to have these NCDs. It starts with, for example, urban planning and design. If we build cities without sidewalks, if we build cities without enough trees, we are in for getting NCDs. So it's definitely something that we need to address collectively as a society and at different levels. It's our mandate to have great interest and to want to contribute to shaping our society in a way that we prevent NCDs for our future generation. In a way also that we are able to address and treat people who are already affected by NCDs in a way that's effective and cost-effective. In Rwanda, NCDs, such as cardiovascular diseases, cancer, chronic respiratory diseases, diabetes, injuries and disabilities, account for an estimated 40% of the premature deaths that we see. Health systems are facing important challenges, providing universal access, containing the rising costs, responding to citizens' expectations, and promoting concerted actions on the wide spectrum of the social determinants. That's why new perspectives for the future and cross-sector plans are required. This year, the Ministry of Health with partners launched the National Strategy and Costed Action Plan for Prevention and Control of Non-Communicable Diseases in Rwanda, 2020-2025. I call upon all the stakeholders to come forward and support the implementation of the National Multisectoral Action Plan to combat NCDs. It's only through such an approach that we will be able to halt the rise of NCDs in Rwanda in an effective, integrated, and cost-effective way. Before concluding, I would like to take a moment to acknowledge the contribution of different partners and the tireless efforts of the organizing team towards the first National Non-Communicable Disease Conference in Rwanda. We believe that the continuation of these efforts will enable us to achieve universal health coverage while preventing and controlling NCDs in our country. With these few remarks, I'm pleased to announce the official opening of this conference and wish you all very fruitful deliberations. Thank you.
Thank you so much, our guest of honor. Another round of applause. And thank you so much for the great remarks by Professor Muchumbitsi. It's really very eye-opening. I can say we are starting on a very good note. Yeah? Or you are so scared by the facts, eh? Are you scared by the findings? Are you? All right. I hope you're not. So before we have our guest honor leaving, we would like to request for a group photo with our partners. Please step out. I would like to call representative from World Bank, yes, and representative from Roche, Defeat NCDs, PIH. All right. So just to remind you that our conference is being followed by by people online. Yes, representative from RBC, please step forward. Thank you. All right. And a few reminders. East Africa NCD Alliance, please. Thank you. All right. So a few reminders. We are conducting free screening from diabetes, hypertension, BMI. If you wish to take one, please look at the tables at the back. All right.
Yes, and please remember to use Twitter and Facebook. You can use the hashtags NCD Conference 2021 or UHC for NCD Conference. And we have participants joining us online on Zoom. So if you can hear us, please feel free to write your name in the chat. And if you have questions or anything else or comment that you want to communicate, also feel free, and we will make sure that we have you participate and join us on this day.
Yes, and we are so very happy for our people following us online as we move forward.
Now, we started a bit backwards because the conference started a bit late, so our guest of honor had other commitments. But now we're going to properly rewind and start as we should have, which is by asking you what you hope to gain from this two-day conference.
Yes, we are having a multisectoral collaboration conversation here. All right? We are talking about NCDs and UHC. What are your expectations?
Yes, I'm sure that the welcome note of Professor Muchumbisi has given us an insight of what the conference is going to be about. He's spoken about the cost of inaction and the burden of NCDs and, of course, the call for action. And we'll be expecting to have a presentation from him in a few minutes about the situation analysis of NCDs. But before we do that, we want to hear from you. So if anyone wants to share with us one key expectation from this conference, please, we'll give you the mic and we can discuss. Thank you.
Yes, we are here to having conversations. All right? Are we together? Are we together? All right, let's hear from Philippa.
Do I have to stand? My major expectation from this conference is the strategies of how people living with NCDs are going to be fully integrated and participating in every aspect of NCD policies, implementation of programs, innovations, you name it, we're ready.
All right. Very important, engaging people living with NCDs. And if you saw on the program, we will have a deep conversation on that. Anyone else? We want to hear your expectations. Thank you.
Thank you. I'm Dr. Julius from AHF. My expectation in this conference is also to hear the strategies for infrastructural support around the integration of HIV and NCDs.
Thank you so much. We can see people having so many great expectations. Anyone else who wants to share? Anything?
Okay, maybe...
You know, we have been talking for, let's say, 20 minutes, but I see people are not well energized. And we are having a great topic, NCDs. We need to be active. Yes? And then we are going to request a favor. We want to start in a very good way, very energized. Yeah? Did you take your breakfast? Did you? Hello. 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 All right. What are we going to do?
I think we are going to allow for a 10-minute break so that we can all gather around the table and have breakfast. And afterwards, then we won't have any excuses for being silent. I hope not. Afterwards, we'll come back here, we'll do an exercise, and then we'll start the day. So please head to the table. But before we do, I want to acknowledge people joining us online. We have Philemon from Nutri-Santé, Rwanda. Welcome. We also have Morten Bach, I hope that I'm pronouncing the name correctly, from Danish NCD Alliance. We also have Ananias Muda Chumura, who is from University of Rwanda. So welcome, and we hope that people keep joining online and keep interacting with us. And then in the meantime, please let's head to the table and have some coffee.
Thank you. We would like to welcome you back. Please rejoin your seats.
For people joining us online, we'd like to communicate that we're back in the conference hall and about to start. And for those still taking your tea break, feel free to bring a cup to your table so that we can go through with the agenda. Thank you.
Feel free to bring your cup or your drink as we continue with the agenda. Welcome back, welcome back. All right, thank you. How was your tea break? Was good? You have some energy now?
Still
Hello,
no
we are
energy.
back. Huh? Thank you, everyone joining us online. Remember to use our hashtags to share the word with the world. You can follow Rwanda NCD Alliance on Twitter. And our official hashtags are hashtag NCD Conference 2021, hashtag UHC for NCD Conference. We are on Twitter, Facebook, and Instagram. Let the world know that we are on a serious business. All right. I think we are all back. Great. So I want to ask you one question. Are we together? Yes. I asked, how was your tea break? Very good. Did you take enough sugar? Yeah? How many people added sugar to their drinks? Especially those who took tea.
That's a tricky question for an NCD conference.
You say?
All the snacks are full of sugar.
All the snacks are full of sugar. Interesting. So I think we need to burn that sugar a little bit. And if you allow me, in your favor, please stand up.
Everyone, let's stand up. I believe our MC has an exercise for us.
Yes, we have noticed there's a lot of snacks there, a lot of sugar. So we need to burn some of them. Yeah? Can you stand up, please? Great. So we are talking about NCDs. And for me, when I hear a word NCDs, the first thing that comes in mind is to be active. I would like to hear when you hear NCDs, what comes in your mind? If you hear NCDs, a word NCDs, what comes to your mind?
We should do more sports.
Great. All right. So everybody's standing up. We are going to do some few exercises, if you allow. Yeah, are you ready? And here are some few instructions. Yes, I can see people are pulling off their coats. Good job. Okay, here is the instructions. I'm going to say one action, and you have to repeat. It goes like, do what I say. Say what I said and do the opposite. Is it clear? Is it clear?
No.
Make sure you have enough space in front of you. So I will say one thing. You have to repeat it before you do it, but you do the opposite. Yeah? Is it clear? All right. Make sure you have enough space in front of you. Great. We are about to be more active. Now, I will say it, you will repeat, and do the opposite. And we're going to see who will do it right. Great. So when I say jump in, you have to repeat and do the opposite. Great. So when jump in, that means you jump forward. Jump out, you jump backward. We good? Okay. 1, 2, 3. Jump in. Jump out. Jump in. You say what I said and do the opposite. Jump in. Somebody say jump out. Say what I said and do the opposite. Jump in. Jump out. Jump in. Jump out. Jump in. Jump out. Jump out. Great. You may join your seats. Thank you so much.
Thank you so much, Claude, for an entertaining exercise. I think in the next round we'll have to call someone from the conference so that they can try and compete.
Yeah, we should have more exercise today. So, as we proceed with the agenda, it is my pleasure again to welcome on the stage our chairman, the chairman of Rwanda NCD Alliance, and the chairman of the East African NCD Alliance. Just for a bit correction, he's not the vice chair, he's the chairman. Welcome on stage, Professor Muchumbitsi.
Welcome. We're going to hear on the situation analysis on NCD and universal health coverage. And I hope that we'll all pay attention. I know we didn't establish any house rules, but for this particular presentation, if we could please fold our laptops and put away our phones so that we can give the professor all the attention he deserves. Thank you.
Thank you all. It's my pleasure to present the results of a study we did on the policies, universal health coverage for non-communicable diseases, and a situation analysis in Rwanda. The screen is behind me, so it is a bit difficult. Trying to get sorry, I'm coming. Yeah. So this study was conducted. We received the Rwanda National Ethics Committee authorization in November 2020, and it was conducted through 2021, and I'm happy to present the results. It was done in partnership with Rwanda Biomedical Center, NCD Division, and the background of the study, it is again the numbers I gave you when I started. It will not take much time around these, but let me remind that one of the challenges of developing countries is also those poverty line, and you see that in Africa, 43% of the people are below the poverty line, and it is estimated at 38.2% in Rwanda. Again, the main NCDs, cancer, cardiovascular diseases, diabetes, chronic respiratory disease, mental and neurological disorders are the major cause of death. The NCDs seem to cause a growing burden of death and disabilities, particularly in sub-Saharan Africa. And as I said, it is projected to overtake infectious diseases as major cause of morbidity and mortality by 2030. The study had a general objective of a comprehensive overview of the policy environment, political landscape in Rwanda healthcare system in relation to universal health coverage for NCDs. I'd like to remind that universal health coverage is to give access to care to all so that nobody is left behind because of financial hardship. In the study, we had specific objectives. We did an overview of existing policies and actions that address NCDs, but also wanted to identify national achievements, challenges, and opportunities within the policy, environment, and landscape in Rwanda. We wanted to identify key stakeholders involved in planning and implementing NCD programs at all healthcare level. And we wanted to identify the roles, responsibilities, and involvement of key stakeholders, particularly people living with NCDs, in shaping national NCD policies and programs. Who did we approach? The study used the participatory approach to engage key stakeholders to collect the necessary information so as we can draw conclusions and suggest recommendations for better practices, policies, and decision-making. Policymakers were involved, policy implementers, international organizations, people living with NCDs, but also academia, civil society, and private sector. During the study, we used different methods to collect data, including desk review, questionnaire, interviews, consultative meetings, and focus group discussions. In the findings, we have identified commendable achievements done in addressing NCDs in our country, particularly the ongoing decentralization of health services toward the community, coupled with the creation of NCD clinics at district hospitals and shifting of NCD-related tasks from doctors to nurses, which have played a role in bringing health services closer to the population, and which are expected to improve prevention and early detection and management of NCDs. As you can see, it is a pyramid, and from down to up, you can see that from the community health workers to the health post, to the health centers where there are already more than 97 NCD clinics. With an NCD clinic in each district hospital, end up you go to the tertiary level and referral hospital. That pyramid is what we call the referral system, and it helps to have everyone have access to care through that referral system. One other major achievement we have found was the community-based health insurance. As we talk about universal health coverage, it covers 91% of the population and 90% of health services costs at all levels of the health care. And in the findings, we saw that its utilization, since it was created in 2003, utilization of health services increased from 30% to 85% in 2008, and screening services for NCDs are also covered by the community health insurance for women over 40 years old and men from 35 years old. So as you see, the community-based health insurance is one of the central mechanisms toward achieving universal health coverage in our country. But in the survey, when we were asking to the participant how the coverage was, of course, the opinion were a bit different. So people approached were finding that 70% of the costs were covered by insurance fully. 25% were finding that it was partially covered, and there was even 5% saying it was not covered. Among other major findings, we can mention the Health Sector Performance Report 2019-2020, which indicates much effort which have been invested in with a focus on the centralization, early detection, and care towards universal health coverage. In the study report, a total of 91 participants from the different categories I mentioned were interviewed, and 94% of them were aware of NCD's negative impact on the national economy. 90% recognized interdependence between NCDs and their risk factors, and among the respondents, 80% were aware they are addressing NCDs, but only 50% said they were involved in planning, and 69% mentioned they were not participating in implementation. The involvement level of stakeholders in planning of NCD program was found to be quite fair at 50%, but the involvement in implementation was low at 30%, which may be related to inadequate multisectoral coordination mechanism, insufficient monitoring and evaluation system, or low levels of program ownership, prioritization, and NCD awareness. The study concluded that the policy environment political landscape in Rwanda are favorable for strengthening the health system in relation to universal health coverage for NCDs. Nevertheless, there are some gaps that have been identified and which prompt us to suggest the following recommendations for better practices, policy, and decision making. The first one is the need for a high-level multisectoral coordination mechanism. The Ministry of Health have just issued the 5 years strategy and costed plan for NCDs, and there are already existing plans and policies guiding, clarifying the list of stakeholders and their specific role and responsibilities in NCD prevention and control program. We believe that a high-level multisectoral coordination committee, ideally at the Prime Minister office level, should be recommended in order to oversee the implementation, performance, and effectiveness of our NCD policies, plan, and program, as well as the accountability of all stakeholders. The Multisectoral Committee would be assisted by the existing National NCD Technical Working Group, which needs to be reinforced and formally created. These would progressively improve the enforcement of laws and policies, the follow-up reporting, research, monitoring and evaluation of program, as well as evidence-based interventions and planning for universal health coverage and NCDs. The second major recommendation is about financing. Financing for universal health coverage for NCDs. Within the competitive priorities, budget allocation to NCD is still a challenge. And as long as large amounts of national budget are relying on outside partners' contribution, it may remain a problem. There is a need to explore alternative financing mechanisms like increased excise taxes, which people call sin taxes, on risk factor commodity like alcohol, tobacco, sweetened drinks, and to earmark at least part of the generated income for NCDs prevention and control programs. Moreover, it is time to think about engaging platforms that attract more investment and private-public partnerships, which would help to cut back the cost of inaction on NCDs. And finally, strengthening awareness and education in the community seems to us as a priority, because with the current mechanism and budget allocation for education and awareness on NCDs, we are not yet very far. NCDs need to be addressed from the grassroots, like through community health workers, civil societies, organizations, and people living with NCDs who can play a role in reaching and educating the community if they are empowered and facilitated enough to collaborate with local leadership for better prevention and control of NCDs. If you want more details, we have issued the report, and it is accessible. We give the information later, but you can have more details about this study. Thank you for your attention.
Another round of applause for the professor, please, for such an enlightening presentation, which I'm sure we'll have a chance to deep dive into as we continue during this conference. Now, without further ado, I would like to welcome our next presenter, the Dr. François Uwinkindi, who is a division manager of non-communicable diseases division at Rwanda Biomedical Center. We're honored to be with him today, and as he discusses the national strategy and costed action plan for prevention and control of non-communicable diseases. I would like to welcome you to please step into the stage and lead the discussion. A round of applause for him, please.
Hello. Good morning, everybody. Yeah, again, it's really a great pleasure to be here today. Sharing what we have in our new national non-communicable diseases strategic plan, and also with its costed action plan for 5 years. And we are here as a country, the first, I can say officially endorsed, approved national strategy to fight these maybe the mic is not working well. So this is, I mean, as the theme for this conference is saying, so we need, I mean, this strategic plan for 5 years, I mean, the key, I mean, goal or the key information that we have is to promote multisectoral collaboration to fight for prevention and the control of these non-communicable diseases. We have understood that the Ministry of Health alone cannot be able to provide a lasting response to these non-communicable diseases. We need to bring everybody on board, civil society organizations, I mean, other government institutions, partners, private sector. I mean, everybody has a role to play in the fight against these non-communicable diseases. So maybe who is moving the slides? Okay. So it's a strategy for 5 years. We have a vision to have a nation free from the avoidable burden of non-communicable diseases. Here we're talking more about, I mean, prevention of these avoidable non-communicable risk factors, because it's possible. Everybody can play a role to reduce the exposure to these known non-communicable risk factors. Our mission, as I've been saying at the beginning, is to enhance multisectoral collaboration, to alleviate the economic, social, and medical burden of NCDs, which will help us to reduce the morbidity and the premature mortality, and then improve functionality, and so that we can have a healthier population. So that's why we are calling everybody to join us, to join the efforts of the Ministry of Health in the fight against these NCDs, because we are, I mean, alone we cannot really do, I mean, many things. And then by doing so, we think that by 5 years, we'll be able to reduce the premature mortality by 25%. This is an ambitious goal, but we know that with all the support that we have from different partners, we should be able to do it. And then we think in these 5 years, we will be able to reach 4.5 million people in these 5 years, either through treatment of these NCDs, prevention, awareness, but also early detection. So as you can see, so the bar is high, but we think that as now we are to achieve it. Next. The first one is about prevention. Prevention of NCDs through tackling these avoidable, non-communicable risk factors. So we know that, of course, you can prevent NCDs or delay the onset of these NCDs. But we know there are also those risk factors that we cannot be able to control. That's why the second objective will be dealing with strengthening the health system to be able to early detect, to diagnose, but also to manage non-communicable diseases. The third objective will be dealing with strengthening, I mean, the monitoring and the evaluation. Make sure that we have got enough information through surveillance, putting in place surveillance systems to be able to have data that will show us, I mean, if what we are doing, I mean, if we are really making that progress that we are intending to do, or if we are on or off target. And then the fourth objective, which is very, very important for us, it's about strengthening intersectoral collaboration and also do advocacy, but also mobilize additional resources. As you know, NCDs, these non-communicable diseases globally, I mean, they are underfunded compared to infectious diseases, compared to maternal and child health programs. And as we have seen, the data is showing that, I mean, the vast majority of people that are dying globally are dying from these non-communicable diseases. So we need to raise additional funding to be able to have enough resources to implement our plans and also strategies. Next slide. So if, next slide. Okay, so if I can talk a little bit more about what are those priority areas in NCDs prevention. that we be doing through promoting, through health promotion, but also, but you know, there are some studies that are saying that any quantity of alcohol is harmful to our health. But here, I think we're saying also avoid alcohol. We should be physically active. There are good initiatives going on. I mean, the country promoting physical activities, but these are things that really we need to continue doing, we need to continue supporting. And again, cut down on salt and also sugar. So I was even seeing this coffee break that we have. So this is an NCD conference, and I didn't find anything about fruits. So, I mean, it was only sugar, it was only, so these are, I think, things that really, we know that, I mean, it's a long journey, but we need to continue talking about them to make sure that really everybody understands. Eat plenty of vegetables and fruits. So we are now conducting a second non-communicable diseases risk factors survey. But if you look at the data we have now, preliminary information, this is an area that we need really to work on, I mean, to push, because, I mean, we are talking about kitchen gardens, but people are not really eating enough fruits and also vegetables. Don't use tobacco products. So these are, I think, and they are also among these WHO best buys for NCDs prevention. So, and we are happy that now on tobacco, we are doing well. Some, because I think it's working, and we thank all civil society organizations or partners that are supporting to raise the awareness of our people. If you look at the results from the last DHS demographic health survey, the prevalence of tobacco smoking has considerably decreased from 12%. Now we are at 3.9%. And we think we should really continue doing, I mean, just doing this awareness so that it can be reduced. So these are, I mean, and then, so priority areas are about continue raising awareness and also education to reduce exposure to modifiable NCDs factors. There is now a program that we're working on promoting or educating these young kids that are in schools about these NCD risk factors. We need to start as early as possible. And then we need to have additional policies that will help us to address, policies and the regulations that will help us to address these issues of NCDs. We have tobacco policies. We are working on alcohol policy. We are also probably very soon start working on policies and regulations on these sweetened drinks, and also those other risk factors on NCDs. And then as we talk also about NCDs, we are also combining with prevention of injuries and disabilities. So we'll be also working with different stakeholders to improve the road safety for prevention of injuries and disabilities. And again, key is to have a strong communication plan to make sure that we can reach to a big number of people down there in our villages to make sure that we do understand these NCD factors. We know what we should be doing in order to avoid the exposure to these non-communicable disease risk factors. Next. So the second strategic objective is about strengthening the health system for quality NCDs, early detection, care, and treatment. As we have seen in the prevention from Professor Muchumbitsi, we are seeing many people coming at health facilities at very advanced stage. So people are not consulting early. We are not doing this regular checkup, even if our community health insurance is supporting members to do this community checkup, but people are not doing it. It's not yet in our culture. So these are things that really we all need to work on. So to have community NCD screening and also early detection. We are happy that now in the new package of community health workers, there are now NCD awareness, NCD, and also NCDs early detection. We think that if these community health workers will do like campaign, door-to-door campaigns, doing awareness, doing screening of, eligible people, we think that we'll be able to early detect these NCDs and also be able to initiate the treatment on time. Again, we don't want to create vertical programs. So these NCDs should be integrated into existing health systems or health services. That's what we are doing in maternal and child health services, in HIV services, so that really, we are targeting all those points of entries. If someone comes for antenatal care, comes for vaccination, comes for those other services at their facility, this is also a good opportunity to talk about NCDs to do also early detection. Again, another priority that we are now working on and should start probably early next year is workplace NCD early detection programs. So, you know, people working in offices, not only in offices, there are people working, with those high-risk jobs, people working in mines, so these, with really a high exposure to NCDs, we should start these workplace NCD detection programs. So this is a program that will be led by the Ministry of Labor and Public Services to make sure that now we are integrating, we have NCDs in different public, private institutions so that people can be detected early but also be educated about these NCDs. So, innovations, self-NCD screening at home and linkage to health facilities. So this is also something that, we need also to promote over these 5 years. How can people get those basic equipment for NCD screening and have a BP machine at home, maybe why not blood sugar testing machine, so that you can even yourself be able to do self-screening, and then once you have abnormal values, be able to report to any nearest health facility, for further investigations, and also be able to initiate the treatment on time if need be. Again, working on early detection, we should also make sure that people have access to NCD medications, laboratory services, and also technology and support services. So, supply chain of medicines and also lab commodities. This is also another critical area that over these 5 years we should be working on to improve. So make sure that we have got these accessible but also quality medicines for our people living with NCDs. Make sure that they can have access to good laboratory services. So artificial intelligence in NCD care and treatment. You don't want NCDs to lag behind. So with the improvement in technology, there are many advances in technology, and then, so there are many things that now we can now also do to use artificial intelligence to be able to improve or also to provide the quick and good services for NCD care and treatment, and also make sure that there is a good psychosocial support, for our people living with NCDs. So again, establishment of specialized NCD and injury diagnostic and also treatment centers. So this is also another area. We know that strengthening the capacity of primary health care facilities, so we'll be able to manage around 90%. If people come early, and also you have services down there at those health centers, district hospitals, we think that we will be able to, to reduce significantly those complications, and also make sure that people can be treated successfully. But you know, there is also another proportion of people that we need these specialized NCD services that cannot be managed down there at the health centers or at the district hospitals. So we need, as a country, to establish the NCD treatment diagnostic services. We don't want to continue referring our people outside the country, where we are sending a very tiny proportion of people in need, and also using a lot of money. So how we should have these services in the country, so that we should make sure that we have enough adequate infrastructure, equipment, but also most importantly, training, enough human resource, so that we can be able to treat our people in the country, but also treated by Rwandans. This is also another plate of the country, and then that's where we are also calling different people, even a private sector to come and work with the government, establishing these specialized NCD and injury diagnostic and also treatment services. And again, a key thing here is also to make sure that we are bringing those specialized services, but make sure that really there is also a financial accessibility. You know, the management of NCD is very, very expensive. There are some of those NCDs, if you look at maybe the cost of doing open heart surgery, of treating some cancers, it's really, the cost is very, very, very huge. The price is very, very huge. But as a government, we should make sure that services are available, but also they are also accessible to our people. Next. So the third objective is about NCD surveillance, research, monitoring, and evaluation. So this is also another area that we need to, to strengthen, because if you look at the number of researches that have been on infectious diseases, especially HIV, really information is available. But for NCDs, we are still struggling to have enough information that can show us really the real cause of these NCDs, mortality, causes. So it's really a green area that we all need to work on together to strengthen research, to strengthen gathering, quality information that will inform our plans and policies, the same information that will tell us if really we are doing a great job, preventing these NCDs. Because you remember, our goal is to be able to reduce the premature mortality from NCDs by 25% by 2025. So we cannot be able to do it without having really robust many systems, surveillance, but also doing really those researches, strong researches to be able to provide responses to different questions that we have around NCDs prevention and control. Next. Yeah, intersectorial coordination. This is our fourth objective: intersectorial coordination, advocacy, resource mobilization for prevention and the control of NCDs. So, and again, if you have, from the presentation we had from Rwanda NCD Alliance, it's a research that we did together. So this is also another area that we need to, put much effort in to make sure that we have a strong and working technical working group. Because a technical working group that brings together different expertise, different people involved in the NCDs prevention and control in the country. And again, this is also a recommendation from the World Health Organization to be able to manage these NCDs, provide a lasting response to these NCDs, should have a high-level committee on NCDs. Because NCDs, it's not an issue of the Ministry of Health, it's not an issue of, all people, all institutions have a role that can play. And then having this national high-level committee that will give a direction to, to different strategies, to different interventions for NCDs prevention and control, we think this is something that is needed, and then we should be able to establish it. Decentralized coordination mechanisms of NCD prevention and control. We don't want it to remain only at the central level. Make sure that also districts, they have NCDs prevention and control in their plans. Make sure that at least we can even go down there at the cell level, at the sector level, to make sure that in what they are doing, they also have some key interventions on NCDs prevention and control. So strong local and also international partnerships. This is, NCD prevention and control is more about, building those strong and also meaningful partnerships. So the government alone cannot really do it. So that's why we need more and the additional partners to come and really accompany the efforts of the government to provide solutions to this serious burden of NCDs. Here we talk about local but also international partners. So we've always been relying on international partners, but then we know that we have also, locally partners that really can play a significant role, that can support the government to in this journey to fight non-communicable diseases. Again, we need also to be able to increase the domestic funding. So the government is doing a lot, but we think that we need to come up with other strategies to be able to increase the domestic funding for NCD response, public and private partnerships. So this is also another key area. We are calling the private sector to come, and because there are many, many projects, especially these specialized NCD services, and I think private sector has a big role to play to support the government to have these centers available in the country. And again, we'll be working on grant mobilization from different funding institutions to be able to have enough resources to implement our strategic plan. Next slide. So this is the cost for 5 years for our non-communicable diseases strategic plan. So we will need around 359 billion Rwandan francs to be able to implement our strategic plan. As you can see, the vast majority, the big chunk of money will be on the second objective, early detection, treatment, care and treatment of NCDs, especially drugs, especially establishing those services that we don't have. So this is where, around 80% of the cost will be. And then the second one will be on the prevention. And that's why, of course, we know that NCD prevention is really that thing that we should be now doing, but you know that it's really one of the, it's more cost effective than even doing this NCD prevention care and treatment. But we know that once we put much efforts in NCD prevention, the cost for the second objective probably in the next 10 years should go down, as maybe some people can also be detected early and also be managed without using a lot of money. On MNE, 5% of our strategic plan, of the money that we need will go on MNE, and then around 0.20% will be on the coordination. This is more about setting up mechanisms to be able to meet people and discuss on different issues that we have. Next. So, again, we have a huge funding gap that we need, different funding institutions, different private sector to come and try to, to bridge this gap. So, and as you can see, the gap will be increasing over time. So, based on the estimate from One Health Tool that we use to cost our national strategic plan, so there is a need to have like annual increase of 20% of the budget allocation to NCDs to be able to raise enough funding that we have, that we need to implement our NCD strategic plan. We also think that health insurances have to expand their health benefit packages, because we have many services that are not yet covered by our health insurances, and then these are especially in NCD prevention. So we want them now to be more involved in NCD early detection, but also prevention. So we need also to shift from reactive treatment to proactive prevention. So we are catching people at a very late stage. So, and what can we do to be active and also be able to have people at the early stage, and then maybe use, less resources for the management of these NCDs. So again, we need also to think about innovative resource mobilization, including cost-thematic and multisectoral coordination. So, Professor Muchumbitsi talked about those assigned taxes, having earmarked taxes for NCDs. These taxes from alcohol, from tobacco, from those other NCD risk factors. Why don't we think about maybe injecting or earmarked those taxes for NCD prevention and control? These are things that I think we should, as a country, continue discussing and also work together to make sure that we raise, we bridge this huge funding gap that we have for our 5-year national strategic plan. So I think this is my last slide. So we thank you so. Okay, maybe let me also allow me to acknowledge the support that we got from different partners, different stakeholders. Developing our NCD strategic plan, the World Health Organization, the Fit NCD Partnership, Partners in Health, Rwanda NCD Alliance, they have been key. Members of National NCD Technical Working Group, different civil society organizations, and also different stakeholders that we worked together to develop our national NCD strategic plan. So thank you so much, and we really, again, we emphasize on having everybody on board to make sure that really, we translate what we have in our national strategic plan into those tangible actions that will help us to reduce the premature mortality by 2025, by 25% in 5 years. Thank you.
Wow, what a wonderful presentation. Let's give another round of applause to both Dr. Francois and Prof. Muchumbitsi for such educational presentation. I hope that both presentations have helped us unpack better the theme of today about multisectoral collaboration, and also shed some light on the big tasks that lie ahead. As Dr. Francois just said, The goals that we've just seen in the National Strategic Plan are very ambitious, but he says that we're now a team and that we should hope to achieve them if we work together. So, of course, we're going to, again, discuss further on the panel discussions that are going to follow shortly, how, as different partners, as civil society, as NCD Alliance, and everyone else that's here today, that we can work towards the goals that we've just been highlighted in both presentations. But before we do that, we want to encourage you, we want to give you a minute to share your thoughts on both presentations, to ask any questions, any pressing questions, if any. And before I give the floor to Claude to help guide us through that conversation, I want to also encourage people joining us online. Please feel free to type in the chat if you have any question or comments, and we'll make sure to include you. Thank you.
All right. Two great presentations from our speakers. And if you have any question, any thoughts, please, you may raise your hands, and then I'll give you the mic. And also, people following us from online, we welcome your questions if you have any. Anyone in the room who has a question? Any thought? You can raise your hand and then I'll give you the microphone. No question? Thank you. You say your name, what you do, and then address your question.
So my question is, for Objective 2, you mentioned one of the priorities will be self-NCD screening, detection programs at home. So can you share a little bit about what that will look like? What does that mean? I know specifically maybe for those who have type 2 diabetes, it's very difficult to get the glucometers to be able to measure their glucose at home, but that's a big part of diabetes care. So is that included in the self-screening? Also, my name is Grace Kelly Muvunyi from World Food Program.
This one is addressed to Dr. Francois. Okay. And from our speakers, if you want to take them at all or address one by one, let me know. One? Okay. One by one?
Maybe, do you have additional questions?
Yes, if you have more questions. Also, we have people from online. We have a question from Arnaud from Dot Pharma. And his question is, how does the strategy consider the role of technology solutions in improved care and access to information? What are the plans to include tech in the implementation? Any other question? Okay, thank you. Go ahead.
Hello, my name is Philippa Dikwi. I am very impressed. I was very, very encouraged and inspired by Dr. Muchumbusi's presentation of the analysis and the outcome of what they've done, which is fantastic. And then Dr. Francois, also his presentation that are really showing and demonstrating the strides that Rwanda is making in fighting NCDs. Now, I have a small question. I always go towards being the voice of the marginalized people. In my work with education and awareness with breast cancer, I have discovered through all levels, they both talked about community-based healthcare, which is covered by the, is it Mituweli and other insurances. There is a big gap and a big need to teach people to use that privilege. They do not screen, even when it's free. I had a chance to present to some well-educated group in one of the businesses, and I asked them how many of them did an annual screening. Only 2 people among 75. Now imagine if that's the case with the middle income sector, what it is like back in the villages. So besides the awareness of NCDs, we are not going to find them unless we do the screening, and we can't afford the mass screening that happens in high-income countries. We have a big gap on teaching and making people aware the importance of taking advantage of the community-based insurance that covers all the screening and free. That's my comment. The others will come later. Thank you.
Thank you. One last question, and then we give the floor to the speakers. Thank you.
Hello, my name is Dr. Nima. I have just one query. In both the presentations, emphasis is laid on the multisectoral coordination, which I do really concur the idea. And in Rwanda, I see there are a lot of partners and stakeholders and CSOs who are implementing a lot of activities in the country. But how do you actually coordinate in reporting and capturing into the national reporting system all the works and activities that is done by different partners? I see there is a lot of gap in this reporting, so how do you actually plan to coordinate these activities? Thank you.
Thank you so much for your questions. We are having a panel discussion after these 2 presentations, so we'll be having more questions. Now the floor is for the speakers.
Thank you very much. Even if it was not really directed to me, I'd like to react to the comment of Philippa about screening access in communities. In fact, it's, I think that's one of the major missions of the civil society. That I said it in one of my presentations. Awareness is not enough. To go for seeking for screening, you need to know that you need to get screening. You need to know about NCDs. If you don't know, you don't benefit from the service. And that's why in our major recommendations of the situation analysis, we have put as number 3, education and raising awareness about NCDs. And we think that civil society has a key role, as you do for breast cancer. All our members do it for cardiovascular diseases, do it for diabetes, and that's why there are so many campaigns. But I would like just to mention that successful countries over the world in tackling NCDs, like Cuba or Costa Rica, they did it in the community. We should empower more the grassroots levels. Community health workers, I know they have already much on the plate, but it should be at that level to know to be able to offer screening education to the household around him, because that's the only way. We are not going, RBC is not going to go educate people in the community. And health centers, health posts have also so much work. But civil society and community health workers, I think we can do it, but we need to equip them with glucometers, with BP machines, with all the tools, and then use digital platforms so that they can access to care. In one of the innovations which is going to be presented tomorrow, we have Babil, there are so many innovations and initiatives which can allow to have access to education and awareness, but also to at least early advice about any screened result.
Yeah, thank you so much, Prof. And if I can also maybe add on what Professor has said, this is really a critical area that we all need to work on together. Education, yes. Education, education, education. We should continue educating people. But even ourselves that are aware of these, of the danger of really of these NCDs, are we getting screened? Philippa has said that, they went to one of these big institutions in the city, and only 2 people are doing regular community checkup. And if I can even ask here in this room, how many people are doing a new NCD checkup? Maybe people will do like this. A few people will be able to. So you see, she's doing like this. So there is education, but we know that it will take time, because the behavioral change takes time. We should continue teaching, we should continue. And we think that we have also other barriers. Probably our screening services are not friendly enough, because if you go to a health facility for only to check on BP, blood sugar, and it takes maybe 4 or 5 hours there, probably people will not really be able to continue going there. That's why we need also to think about those other innovative ways. How can we promote self-screening? How can we promote really community-based NCD screenings? How can we make sure that even we have, because you know those very long queues that are at different health facilities, how can we really make sure that we don't mix those people coming for only checkup with those ones coming for curative issues, or so these are things that we need to continue working on together. But at least, even in those available services, we should be able to use them. We are happy that now we are also thankful to the World Bank and the other partners that we have here that are supporting a free NCD screenings. All health centers, they have got those, enough consumables and equipment to be able to do this NCD free screening. But people are not going there to use it. So that's really where, we want, again, civil society and local leaders, everybody, to go down there to teach people about these services that are available. And also, I think that now, with the community health workers' support, doing door-to-door education and also NCD screening, we think we should be able to now to detect many people with NCDs, but also at early stage. Because I have, here we came here with our cars. So all our cars have got that annual technical inspection, because it's mandatory, because it's being enforced by the police. But if you go for that technical inspection for your car, remember also to go and get this NCD checkup, because it seems that we like our cars more than we love ourselves. So this is, but we know it's something that will take time. But I think if you look at where we were maybe 5 years back and the where we are now, it's really encouraging, and we should continue working on that one. So technology in the implementation of our national NCD strategic plan, because you cannot, Maybe tomorrow we'll have, even today, some sessions on those innovative, let's say, digital solutions that can help us to go faster implementing our NCD strategic plan. So I think now there are many, many innovations in screening, artificial intelligence, in diagnosis. So I think technology has a big part that will play in the implementation of our NCD strategic plan. Maybe I want to go into more details tomorrow or today. You will have those, examples on how we can use technology to move faster. Home-based NCD screening. Yes, this is also another, new priority. But we have started doing it, especially for these kids with type 1 diabetes. We are providing strips, we are providing those blood sugar machines, and so that they can also be able to check themselves and see how is their blood sugar. So it's really working, but of course there are still some challenges because they screen, but do they have tools to report back to the health facility so that at least the treating nurse, the treating doctor can see those values. So this is where we need now also technology to help so that we can link home-based screening and also with the health facilities so that, people can be able to report those numbers that they are seeing at the screening. So reporting to NCD strategic plan, yes, this is also another huge gap. We have different civil society organizations, different partners that are also doing different interventions activities towards NCDs prevention and control, but are we having together those reports? So this is also another area that we need to improve on over these next 5 years. As I said, we are putting in place a high-level national committee on NCDs, and all actors that are in this fight against NCDs should be reporting to that high-level NCD committee so that we can be able now to see who is doing what, are you doing the right progress, we are not having duplications. So, and I think that's the only way that we can also be able to, join our efforts and not really having many duplications. And I think this is also something that we need to improve on over these next 5 years. And I think these were the questions that were asked, and thank you.
Thank you very much, Professor Muchumbitsi and Dr. Francois, for answering the questions. I know we had more questions in the audience, but soon we'll have a panel discussion on this topic of multisectoral collaboration. So I'd say hang tight and we'll get to you and we'll discuss whatever question that you had. But before, I want to acknowledge someone also on the group chat who had a question, and we'll get to you in a minute. But before we jump into the panel discussion, I'm happy to welcome one of the most distinguished guests today, the representative of World Health Organization in Rwanda, Dr. Brian Chirombo. Again, I hope that I'm pronouncing the name right. Dr. Chirombo is a public health leader with over 30 years of experience, and on top of that, he has research and academic experience in non-communicable diseases. We couldn't be happier to welcome him today with us and to hope to learn from him in the next few minutes. Welcome.
Thank you very much, Master of Ceremony, the President of the Rwanda NCD Alliance, representative from RBC, distinguished guests, colleagues, ladies and gentlemen. It is our honor as WHO and as representative of the World Health Organization to be part of this very important conference on non-communicable diseases, this national conference, which aims to accelerate, and particularly this session, pushing the multisectoral actions in responding to NCDs and universal health coverage. As we all know, NCDs, and we've already had in the opening sessions, that NCDs are globally recognized as the world's leading cause of morbidity, of disability, and of death. I think in the session that we just had, we heard about some of the challenges we still have with identification of NCDs. So there are two problems, the issue of identification and treatment, but there's also the big problem still of prevention. We know that with the COVID-19 pandemic that we're still experiencing, one of the things that COVID did was it unmasked a lot of the non-communicable diseases that we were not seeing. We know that during the COVID pandemic, a lot of the people who succumbed to the pandemic were actually those who had non-communicable diseases. I think this, to some extent, has helped to bring to the fore the critical importance of non-communicable diseases. Yes, we had all this information and all this data about the impact of NCDs. But if we really look at the world and where we are, it's very clear that the focus has still not been on this very important area of NCDs. We know that the Global Action Plan, so WHO, working with partners, developed the Global Action Plan for reducing NCDs. And this included what we call the best buys, which we will talk a bit about. We've already heard about it, but I think during the next session, we will talk a bit more about it. For tackling the key risk factors, such as the tobacco use, which we just heard about, physical inactivity, which is a big problem, the harmful use of alcohol, and unhealthy diets. And it recommends multisectoral action, engaging all of government, as well as other sectors, including academia, non-governmental organizations, so the whole civil society, philanthropies, and the private sector. So stakeholders also, and it's very key, and we have heard just now, should not just be these sectors at national level. It's very important that we go to the sub-national level and to the municipal level and to the local level. And we already had, from what Prof was saying, that's really where the action needs to be, at the local community level, if we're going to make a difference. We have seen in other regions and other countries where the action at the local level has been stronger. We have seen that we have made more progress and quicker progress towards addressing NCDs. So I think what's key is to emphasize the whole of government and the whole of society approach in addressing NCDs. So it's key to realize it's not the responsibility of Ministry of Health to address NCDs. And the reason is because the causes, the impact, are all outside, largely outside health. Of course, when people have NCDs, they will be recognized in the facility. But the reason that they get there is actually less to do with what happens in the health sector, but has to do with everybody else. So the whole of government approach is key to make sure all sectors contribute. And also, we need the whole of society approach. And we have already had that we need to make sure that not only is it about health workers, but we need to talk about going beyond the usual health workers to community health workers. We need to go beyond to the civil society. We need to go and involve people who are living with NCDs. So the whole of society approach is the only way that we will be able to adequately address the NCDs. And we know and we see from experience that countries that are making good progress are doing that. Yes, we are seeing those good examples in Rwanda, but we need to do more. We need to see more if we are going to have a big impact. So, President of the NCD Alliance, colleagues, ladies and gentlemen, so we already heard about the presentation of the national strategy for addressing NCDs. And I think this is very encouraging that this is our second national strategy. Obviously, we have learned from the experiences of the previous strategy. And I think it's a very good strategy that ensures that we have the interventions clearly defined. We have defined the key stakeholders and who needs to be involved. What is critical is for us to now make sure that we implement. So it's less about the paper and the document and more about the actions that we will need to do to make sure that we can address NCDs. As I have re-emphasized, and I will keep re-emphasizing, we will never be able to deal with NCDs if the Ministry of Health is the main implementer. We have to look beyond the health sector to the wide range of actors. So education has to be involved. NCDs is something that needs to be, or dealing with NCDs, needs to be inculcated. It needs to start from a young age, because the impact that we see on NCDs later on in life, these seeds actually start from the young age group, from ECD, from young people. So if we don't involve the education sector, we will not be able to effectively deal with the problem of NCDs. Agriculture, the diet that we eat. We know that we have major issues with poor diets, with bad eating behaviors. So unless we engage agriculture, we grow the right foods, we encourage the use of local foods, healthy foods, and we deal with bad foods and discourage their use. If we don't do that, we can talk as much as we want as health sector and even as civil society. We will not be able to make the difference we need to make. Sports, inactivity is a big issue. Yes, we are doing a lot. You know, we have the car-free days, we have so many that we are doing, but we need to go beyond that in the area of sport. And Ministry of Sport needs to do more. Transport, talk about the cars. How do we deal with the issue of transport to make sure that we encourage ourselves to do more walking and less sitting in cars and buses? Urban planning, environment, the whole area of the environment. Private sector, when we look at the other sectors. Civil society, we've already talked a bit about. So again, re-emphasizing that we need to have a whole of government approach, which definitely goes way beyond health, and a whole society approach, which definitely goes well beyond the health workers. So Ministry of Health has led, through RBC, the development of the strategic plans, and we have the guiding principles, we have a clear list of stakeholders, we have specific roles and responsibilities that have been defined, and we just heard about the different areas that we need to focus on, including on prevention, on control, on care, on treatment, and what we need to do. The World Health Organization, through the member states in the World Health Assembly, has recommended, among many other things, ensuring that we have a high-level multisectoral coordination mechanism at country level. And we've already had the work that's starting in Rwanda to put that in place, or at least make sure it's functional. We have, just as we have looked at other areas, leadership has to start and be done from the front. And we need this high-level coordination that is multisectoral, that goes well beyond health, to help with coordinating, because it's there that we need to make sure that these plans that have been developed, that are in place, are implemented, that we are performing to the level that we should, which means that we have to keep monitoring how we are doing. And it needs to start off from right at the top there. And make sure what we are doing is effective. Is it making a difference? Are we making a difference? For example, when we look at accidents, how are we doing? Are we making a difference with regards to alcohol? Are we making a difference with regards to tobacco? Yes, I think tobacco is one of the areas we have done better. And as a country, we already had some of the indicators to show that we are making progress. But the problem is we're not there. There are still gaps, even in the issue of use of tobacco. Tobacco is something that benefits us absolutely nothing, zero. It's not something that gives us any benefit. All we get is harm. So we need zero use of tobacco. So there are even areas where we are doing well. We need to do more. And we know that there are many areas where we are not doing well. And therefore, the issue of performance, the monitoring, the issue of effectiveness, and whether we're getting where we need to be, the issue of the plans that we have developed, are they actually really being implemented? It's nice to have good plans, but it's the difference that the plans make on the ground that we need to focus on. And of course, accountability. And that's why I'm emphasizing the high-level multisectoral coordination committee or whatever structure that we put in place. Because it then ensures that we have leadership from the front. It ensures that the different areas, sectors, and partners are held accountable. If we don't hold one another accountable, it's usually difficult to ensure that all of us do our part. So I really wanted to more emphasize that there's obviously much more, and we've already heard about how we need to go beyond. We need to decentralize. We need local action. We know that without local action, it will all be actual talk. So we have heard about the national strategy, and I think we have done well. But what we really need to do is to make sure that that is implemented. So the alliance is a very key part, and we're going to talk a bit more about multisectoral coordination. I think the bigger gap we still have is ensuring that all the sectors are fully engaged in doing their part. And secondly, the other part is making sure at the different levels, it's not just at national level, it's not just about national conferences, it's not just about speeches, it's not just about, having the Minister of Health talk. It needs to be to move down to the municipalities. It needs to go down to the local level. It needs to go down to local civil society organizations, local NGOs. Yes, the big ones are good and important, but really the one that will make the most difference is the community-based organization at the grassroots level. Those are the ones which will help us to really make a difference. So I think this session is a really critical session where we need to engage and talk about how do we make sure that the multisectoral collaboration in NCDs work. Because we know that's the Achilles tendon. Without it, we're not going to go anywhere. But we need to come up with strategies on ensuring that the multisectoral collaboration and coordination works. We need to make sure that it moves beyond the national levels to the local level. We need local action. And that means all stakeholders have to be involved. It's only then that we will be able to make this big difference. Like I was talking about in education. We're not going to make, yes, the big campaigns are important, but to really make a big difference on the understanding on diets and what children need to eat so that they start early. It needs to be at the local level, at the school level. So I really am emphasizing that it has to be local. Otherwise, we will keep talking, we will keep singing, but we will still see little difference. And for us to do that, I think we have the stakeholders sitting in this room. And if we can agree on how we do that at local level, and make sure that when we move from here, we then begin to have this local action at the local level, we will begin to make progress in beginning to really address NCDs. Yes, it takes time. Yes, it takes a lot of work. But we need this local action to actually be able to do that. So I really am looking forward to the panel discussion, and I'm hoping that we go beyond the panelists. Yes, the panelists will give thoughts and ideas, but I think it's about us. Let's start putting our heads together and coming up with ideas that are practical, that we can take up from this conference, and then begin to make that local action. So I really want to keep re-emphasizing, it's the local action that we need. And if we can come up with ideas on how we get that local action to work, then I think we will begin to make more progress towards addressing NCDs, which we know is becoming the real killer of our people. We know is the one which is really causing the disability among our people. And it's the one which is really causing or has the highest burden of making people sick. And therefore, we need to address it, and address it now. And together, we can address and defeat and deal with NCDs. Thank you very much, colleagues.
Thank you very much indeed. Another round of applause to the WHO Director, Country Representative. Indeed, we are doing very well somewhere, but we need to do more. Thank you for your powerful message and the greater call for actions. We still have him on the panel that is going to come up next. And remember, WHO, it connects nations, it connects people and partners to expand universal health coverage. So we couldn't have a better time to have you with us. Thank you so much. Our next panel discussion is going to be led by Karara Jackson, who is a pharmacist. He works at Rwanda FDA as a specialist in drug regulations and drug quality and safety standards. Welcome, Karara, to introduce your panelists.
Good morning. Good morning. It's a pleasure to have you this morning in this wonderful conference that is hosted in Rwanda for the first time, a conference that is expected and anticipated to make very strong resolutions towards the fight against NCDs in Rwanda. We are going to be emulated by other countries as the spearheaders of the fight against this trending cause of problems in our society today, NCDs. It's a pleasure also to introduce our panel. I have a panel of very strong people who are going to contribute immensely on how we are going to collaboratively work together and ensure that we reach the goals and the standards that have been set as per the strategic goals and the WHO amendments towards NCDs. Allow me to honorably introduce my panel, who are going to step forward, take their seats, and we start the moderation of the panel right away. The first panelist is the WHO Country Director, Dr. Brian Chirombo. Please take your seat from your sitting position. Can you give him a round of applause? The second speaker is going to be the RBC NCDs Division Manager, Dr. Francois Winyenti. Other rounds of applause. The third speaker is going to be from Rwanda Healthcare Federation, who is also the Managing Director of NCD Conseil, Dani Mutembe. It's a pleasure. And lastly, we have the Rwanda, people living with NCDs, the Rwanda Stroke Action is a civil society entity, and it's going to be represented by Dr. Joseph Lukeli-Buga. It's a pleasure. Welcome. So, right away, I'll not take long. I'm going to read their bios. Allow me to read their bios because it's very fundamental. I will start with the WHO Country Director. Dr. Brian Chilombo is the WHO representative Rwanda from 1st October 2021. He's a public health leader with over 30 years of progressive professional experience in leading, managing, and implementing development and cooperation programs at national, regional, and international levels. He has experience in managing multidisciplinary and diverse teams of national, regional, and global levels, supporting governments, international organizations, and the UN, which has given him a good understanding of how to work in the international, diverse, multicultural, and gender-sensitive environments. He is also an academic teaching and research experience personnel in both communicable and non-communicable diseases. During his last 30 years, he has provided strategic guidance and advice to governments and UN senior leadership in health policy development, policy dialogue, partnership building, health system strengthening, and resource mobilizations, including in areas of communicable and NCDs. Dr. Brian Chirombo is a medical doctor with a postgraduate master's degree in public health from Emory University in Atlanta, Georgia, USA. Thank you. The second, we have Dr. Winyenti Francois. Since 2020, Dr. Francois Winyenti is the NCD Division Manager at RBC, Rwanda Biomedical Center, an independently governed coordination and implementation arm of the Rwanda Ministry of Health. He previously served as the Director of the Cancer Disease Unit in 2015 to 2019. Prior to joining the Cancer Control Program, he spent 5 years working in National HIV Control Program with different roles and responsibilities in prevention, care and treatment, monitoring and evaluation, and clinical research. As a researcher, he has authored in more than 10 publications in peer-reviewed scientific journals in scientific journals. In 2017, he received Cancer Young Leader Award from Union for International Cancer Control, IUCC, over his achievements in cancer control in Rwanda. Dr. Francois is responsible for coordinating all activities related to reducing the burden of NCDs in Rwanda, including cancer, cardiovascular diseases, injury and disabilities, and diabetes, lung, renal, and other metabolic diseases. Francois received his medical degree in 2008 and his master's in epidemiology in 2013 from the University of Rwanda. Third, we have Dani Mutembe. He's the CEO and founder, Conseil Medical Supply and Vice President and co-founder of Rwanda Healthcare Federation. Dani Mutembe stands at the forefront of the fastest moving pharmaceutical field within the wider East African healthcare industry with 18 years of experience. He's the founder and CEO of NCD Conseil Medical Supply and managing partner of Pharmacy Conseil established in 1983. Dani is also the Vice President and founding member to the Rwanda Healthcare Federation. He's the former chairperson of the East Africa Healthcare Federation and a board member of the Africa Healthcare Federation, East African Health Platform, Maghreb Pharma Expo, the Rwanda Biomedical Center, and Ubuzima Foundation, among others. Dani was a lecturer at the University of Rwanda, an external examiner at Mount Kenya University for several years. He's a consultant in the pharmaceutical sector for local, regional, and international organizations. He holds a master's degree in pharmaceutical engineering and industrial technology from the Université Catholique de Leuven, UCL, Brussels, Belgium, where he was awarded with the Willy Lohest Prize in Pharmaceutical Engineering and Industrial Technology. He's also the member of the Federation of East African Pharmaceutical Manufacturers and the chairperson of the Rwanda Private Pharmacists Association, APOR. And lastly, is from Dr. Joseph Rucheruba. He's a veterinary medicine degree holder with a master's, and he has served under different platforms. He has a master's degree in animal science in the Institute of Animal Production program, University of Rennes in France. He also has a doctor of veterinary medicine from Interstate School of Science and Veterinary Medicine, Dakar, Senegal. He has an experience, and he worked with CDC Rwanda laboratory team lead, and also he participated in the mentorship in training and evaluation of influenza sentinel surveillance system in Africa organized by CDC in collaboration with Institute Pasteur and ASLM. He also been a facilitator in the training on Ebola preparedness and response in Rwanda. Please. It's a pleasure now to start the discussion with all these key personnel in front of us. And we have very crucial discussion, especially from the point of view on what actions are we going to take right away. We have already identified NCDs, we know the predisposing factors, and finally, what is our role to ensure that we either prevent, we contribute in the prevention, in the diagnosis, in the treatment, and even the management of the current rising trend of NCDs. Maybe from the other end, I can start with a question on, from the WHO country director. And the first question is going to be related to what WHO has been doing in terms of strengthening the systems. Remember, we have an interaction session. We shall have questions from the online participants. That is the Zoom meeting. Please text your questions there. We shall read sample some of the questions and give the panelists. We also have other social media accounts. We have the Twitter handle, and we have the 2 hashtags. Make sure that you get the hashtags and drop your input or question, and it shall be handled. From the WHO perspective, we are honored that WHO introduced the best buys and the best buys interventions. Could you please kindly elaborate this on the best buys and these interventions that WHO has taken so far?
Thank you very much. Thank you very much, moderator. Yes, I think we already had in the morning in the presentations about the best buys. And so I'll just highlight on some of the key ones. So we talked about the issue of tobacco use. It's one of the critical areas that we need, where these best buys are included, their interventions. And obviously the first one, which I think I heard Dr. Francois was talking about already, is the issue of increasing excise taxes and prices of tobacco products so that we can discourage the use of tobacco. So that's one of the interventions in the best buys. And then secondly, addressing the issue of packaging, because we know sexy-looking packages, particularly for young people, draw them. So ensuring that there is plain, standardized packaging and all graphics which show the health warnings on the cigarettes packages. And then enacting and enforcing comprehensive bans on tobacco advertising, because we know advertising is a very powerful medium, and particularly for younger people. And also banning the use of sponsorship by tobacco companies. And then making sure we eliminate secondhand tobacco smoking. So even though tobacco smoking affects the person smoking more, secondary tobacco smoking does affect particularly younger people, pregnant women, quite a bit. So making sure that we address workplaces, public places, and reduce exposure to secondhand tobacco smoke. And then, of course, the whole area of mass media campaigns. We need to make sure that we implement effective mass media campaigns. And those are some of the interventions among the best buys with regards to tobacco use. With regards to harmful use of alcohol, again, the issue of increasing taxes and on alcoholic beverages is critical, and we have seen that it's been quite effective in a number of countries. Of course, this is not a one-all intervention. It needs to continue to be stepped up. And then, of course, the same as we have talked earlier on banning comprehensive restrictions on exposure to alcohol and advertising. And then enacting restrictions on the availability of alcohol, particularly really focusing on the younger people. I think maybe I can stop there in case there are questions. So I've just highlighted for tobacco use and alcohol use.
Thank you. You just mentioned about the best buys interventions that you think and see that is going to be paramount. Dr. Francois, you know, it's a multi-sectoral approach. There has to be a collaboration between different factors. And remember, some of these are going to be economical and it's going to have some impacts. What is the current government strategy to prove or to beef up the realistic framework towards the implementation of these multi-sectoral approaches? Dr. Francois? Dr. Francois, the WHO director just mentioned about approaches that is going to involve other sectors, like the tobacco industries, the promotions, like the mass media and so forth. So what is the government framework, the realistic framework government is going to use to ensure that all these stakeholders come on board and they contribute towards the implementation of these best buy strategies?
Yeah, thank you so much. Sorry. So, yeah, I mean, these best buys have been there for many, many years. And the countries at different levels of implementation. So there are those really, risk factors that we clearly know that are really common in all communities, not only maybe in developed countries, but also in our low and middle income countries. We talk about tobacco, alcohol use, health diet. So these are, people that are, things that are fueling this NCD epidemic. So locally, I think we have been working on it because addressing these NCD risk factors, you need to have policies and regulations in place. Legal instruments that will help you to make sure that you have those frameworks that are helping you to address those NCD risk factors. But also having regulations is one thing, but also have frameworks for implementation or for enforcing those regulations. If I can say, maybe again give an example on tobacco. This is where maybe we are putting much efforts, and we are happy that now we are having good results. So we've been having a tobacco policy for the last, I think, even 10 years. So we are even now revising it to make it much stronger, to make sure that it's very aligned with those these international or FTC recommendations. And also it's one of those policies or legal instruments that have been well implemented. We are no longer seeing really those aggressive, even tobacco advertisement. It has been, I think, maybe we are seeing some of those few sporadic adverts, but we are no longer seeing people advertising tobacco in the public. We are no longer seeing those billboards on the roads talking about tobacco. So these are things that really have helped us to reduce the prevalence of tobacco smoking. But we still know that, there is still a long way to do. So because, people are still selling tobacco maybe in those, small shops, people are still, because there are still some of those other activities that we still to improve on. So selling tobacco in those prohibited areas, tobacco in children or in people who are below the age. of course, there is no age of. But if you see in our regulation or policy, normally you should not, the parents should not send a kid below 18 years to go and buy tobacco for the parents. But we are still seeing those things. We are still seeing those things maybe. I mean, small shops still selling tobacco, and you can, that tobacco is still displayed where people can see. So these are things that we still need to work on. Public smoking. This is also another area that we are working on together with the national police. So, and I think for tobacco, at least you have those legal instruments in place, with legal frameworks, and all stakeholders really are on board to make sure that really we fight tobacco. But now we are about to embark now on alcohol, because this is really a very, big fight, and we want everybody to come on board, put in place. Because we know always when you start tackling those NCDs factors like tobacco, alcohol, there is strong resistance. We know these alcohol industries, they are very strong. They are also contributing some, to the development of the country through paying taxes. But we need also to have this, we are still talking about harmful alcohol use. So how can we make sure that really we are protecting exactly our young kids, not really drinking, not being exposed to alcohol? How can we regulate the, how can I call it, counterfeit, alcoholic beverages? These are things that are really causing much issues, on our people. So I say that, there are many things to do, but we are happy that now we have a good guidance from the ODF organizations. There are also countries that have done it before. We can learn from each other and see how we can even improve and have really those, implement those best buys and also be able to reduce the incidence of these NCDs in the country. Thank you.
Thank you, Doctor. Mr. Mutembe, actually, the government has been promoting and enhancing the private sector involvement towards the enhancement of the economy and even the health sector participation. There are policies in place, there are regulations in place on how to combat NCD trends. Do you think the private sector has been involved, have been participative in designing these policies and regulations that are going to be implemented, and not forgetting that their considerations towards the fight against NCDs is very important at the receiving end, because they are the ones who take opportunities in business, and there must be a win-win goal. Do you think the private sector has been involved, and is there any win-win opportunity that can be helped to fight against these trending NCDs?
Thank you very much, moderator. This is a very important question. The private sector has been trying hard to organize itself around government policies and regulations, but also government priorities. Government priorities are private sector responsibilities. The private sector should be involved at all stages of government decision-making. The beauty in Rwanda is that this is happening. Private sector is engaged. Private sector is consulted. But again, there is a long way to go, because we see that private sector has some technicalities that need to be used. I'll give you an easy example of during the COVID response. As the Pharmacists Association, we spoke with the Rwanda Biomedical Center and told them, listen, we have 300 free facilities for institutions to use as point of information, for instance, and point of of testing. So those are things that need to be taken into consideration. But we come a long way. the Rwanda Healthcare Federation, for instance, is a federation that brings together different associations, including the medical associations, medical doctors, pharmacists, nurses, etc., all actors in the health sector. And it's being engaged in different policy making and different meetings regarding the NCDs. But we see that there is a lot to be done. When you look at the plan of action, the 2021-2025, you will see that a huge portion, it's close to 90%, that is about supply chain and procurement of medical commodities. Pharmaceuticals include medicines, but also medical equipment, medical devices, consumables, etc. So this is an important and huge opportunity for the private sector. Not only a for-profit opportunity, but it is an opportunity for research, for instance. We see that pharmaceutical plants, pharmaceutical manufacturing plants are setting foot in the region, are setting foot in Rwanda particularly, but there has been delays because of regulatory frameworks, because of different policies that had to be put in place. Now they're in place, and it's happening, and it's going to create so much drive towards fighting NCDs, for instance. If you looked at the African Continental Free Trade Area, the Africa Healthcare Federation has been engaging the CDC, WHO, and other organizations to create that awareness with different members of the federations. Just to give you a quick highlight of the Africa Healthcare Federation, it brings about 5 big regional federations, which are the East Africa Healthcare Federation, which actually helped creating the other federations, but you have the West Africa Healthcare Federation, the Northern Africa Healthcare Federation, the Southern, and the Central Africa Healthcare Federation. And there has been engagement, you know, with other federations, for instance, Nat Health, which is an Asian federation from India. It's the equivalent of the Africa Healthcare Federation. And there has been sharing of best practices. So that awareness has been created in the private sphere, but more importantly in the pharmaceutical sector, where pharmaceutical manufacturing has been pushed forward. Local manufacturing, local pharmaceutical manufacturing, but also regional pharmaceutical manufacturing. Most of you are aware that there is a joint inspection in East Africa where a manufacturer can register in one of the countries and get his product approved in other countries, of course pending a few checks, but that joint inspection exists, and that has facilitated investors and manufacturers to have products circulating in the region. Unfortunately, there are still barriers and challenges that we face. For instance, the pharmaceutical sector is a $65 billion in Africa, but you have $1 billion which is focused on counterfeiting or manufacturing of counterfeited and substandard products. This means that while we are seated here discussing about how we could fight NCDs and fighting counterfeited products, malaria products being one of the most counterfeited class of products, some other people are seated countering these actions. My predecessor speakers spoke about smoking and cigarette. There is a manufacturing, a huge pharmacy distributor in one of the Western country, I'll just shy his name for now, who in the front office, among other over-the-counter product, had a secret package, being sold. So there is also a huge paradox in this fight against NCDs. There are good motions, good movement forward, but there are also challenges that need to be addressed now for us to move forward faster. And the private sector is engaged, and unfortunately, those small, I would call them small people or organizations affect the image of what the private sector would do. I'll just stop from here.
Thank you so much for the response related to the private sector engagement and the opportunities that they have derived out of the current policies made in place by the government and government priorities, especially from the pharmaceutical sector. This is where we have the diagnostic equipments, the medical devices for the tests of the NCDs. We also have the medicinal products. These are certified and approved by the regulatory bodies. It's very important that this sector also thrives. From the civil society perspective, Dr. Joseph, we have people living with NCDs. They are the ultimate end recipients. The WHO director mentioned in the morning that we need community-based interventions at the grassroots levels. Are these people living with NCDs given an opportunity to participate in decision-making? Are they part of those who are going to have a voice in order for their issues to be advocated? Do we have such kind of mechanisms in place where they are involved and they also want to be participative in the decision-making?
Thank you, moderator. I take also this opportunity to thank the organizers of this conference to give me an opportunity to speak at this panel. People living with NCDs like me want to be meaningfully involved in NCDs response. That means they want to be given an opportunity to participate in many different facets of NCD response, such as raising awareness, research, policy making, program planning, implementation, monitoring and evaluation, and even accountability. This is the only way to get those interventions be effective to really prevent and control NCDs.
Thank you for the highlight that they should be involved, and for sure they are part and parcel of this global problem. From the WHO perspective, I would like to get a point of view from your side. WHO is a developmental partner, and especially to many political aspects of each member countries. We have some strategic plans that have been devised by the member countries for the case and context of health sectors in each member country. We are currently facing some gaps, the financial gaps. How do you think this is going to be counteracted and ensure that the government meets its priorities and goals with the current deficits that we have?
Thank you very much, moderator. I think maybe before I respond to that question, let me just finish off some of the other best buys that I didn't talk about, okay. But I'll do that very quickly because I think they are still critical. So in addition to tobacco use and harmful use of alcohol, the unhealthy diets are another big one. And unfortunately, that's an area that's actually growing. And some of the best buys there relate to the whole formulation of food products. And I think we already heard from Dr. Francois about the issue of legislation. We need to make sure that we have legislation that legislates on the formulation of food products to ensure that particularly we deal with the issue of salt so that we have less salt in our diet and also some other...
We can close the mics, we can switch off the mics for those ones who are not using them.
Yes. And then we need to have a supportive environment, and I talked earlier on about schools. We need to start early. Hospitals, nursing homes. We need to make sure that the whole mass media communication addresses the issue of diets so that people are aware of the issues with unhealthy diets. And then finally, the issue of labeling. It's really important not only to teach people for them to look at what's contained in the food, but also making sure that companies actually do the labeling. And then the whole area of physical inactivity. So in terms of campaigns, in terms of motivation, education, environmental programs, etc. So I just wanted to also highlight that. So with regards to resourcing, so we know that the biggest problem, so I mentioned earlier that the bulk of the causes of morbidity and mortality and disability is actually non-communicable diseases and the risk factors associated. However, when we look at the funding globally, and that's looking at all partners, the donors, the development partners, government, etc., most of our funding still goes to infectious, particularly the infectious diseases. It's important, we have to address them. But we have not moved to a stage where we also begin to address NCDs, which are becoming real drivers of morbidity, mortality, etc. So that's the background that we have to look at. The challenge is there is already a mismatch and there is inadequate resources. So, and part of created specifically to help with mobilization, for example, the Global Fund, which has been very influential. So we did not have any in the area of NCDs. So the UN, particularly with the leadership of the 3 UN agencies, so that's the World Health Organization, that's UNICEF and UNDP, have helped and are putting together a United Nations multi-partner trust fund, which would then catalyze the mobilization of resources. And this trust fund is going to develop a strategy, it's going to bring in partners, and the objective is not only external funding. I think it was Dr. Francois who talked earlier on, that mobilization of local resources, domestic resources, is critical and actually needs to be where the focus is. But of course, we need catalytic funding from donors, from development partners. So it's going to work with all partners to ensure that we get more investment. Because really with NCDs, it's not really about spending. It's actually about investment. Because when we look at the negative impact of NCDs, and in all areas, it's an area that we have to invest so that we actually get the goods, the best buys, the benefits that we need to have. So to encourage investment by the international community, by the donors, by multilateral partners, but also domestically. And I think here domestically, we're talking about governments. Government will need to put more resources. So Rwanda is putting funding into NCDs, but it's not enough. So government needs to put more funding. And here when we're talking of government, again, we're not talking of Ministry of Health. We're talking of, remember we talked about the sectors. Education sector needs to put resources into addressing the issues that relate to them. Sport, etc. And then the private sector, we already had from AHF. It's a critical area which we haven't tapped adequately. I mean, if people are not healthy, who is the private sector going to be selling their products to? So it's really an investment that the private sector needs to do in the health of the communities. And NCDs is a critical one. The private-public partnerships. We need to have public-private partnerships. We talked earlier on about the issue of gadgets that we need to be able to do home screening. We know that companies do produce these gadgets. And as part of their responsibilities, we need to have public-private partnerships where the pharmacies would also donate some of these, would work with other partners to make sure that we have this. So when we're talking of funding, it's not just about money, but it's all the resources that are needed. Civil society needs to come in. And I believe that all programs, regardless of what they are, whether they're HIV or whatever, we know that we are busy preventing people dying from HIV. But as people live longer, then their chances of developing NCDs is getting higher. So we need to make sure, because our aim should be about a healthy life, about long life. It's not about preventing a disease. Because if we prevent someone from dying from one disease and they die from another, it's really not very helpful. And we know NCDs are now the biggest killers. So I think even in all the programming that's done by all partners, we need to make sure that we put in money that also addresses NCDs. So basically, the resource mobilization needs to be across all sectors. It needs to involve all partners, so global, regional, national, and we talked a lot about the local level. We do need to make sure that even at the local level, we're mobilizing resources in kind and in terms of funding to make sure that NCD is adequately funded. Because without adequate funding, we can have nice plans, we can have all this stock. It's not going to make any difference. So this is what WHO has now been working, particularly with UNDP and UNICEF and other UN partners, to push the mobilization of more resources so that we can be able to mobilize enough resources for implementation of all these plans. And then we'll be able to make a difference in terms of NCDs. Thank you.
Thank you so much for the catch-up. The WHO is an important developmental partner, and as it tries to mobilize more resources for the national implementation of strategic plans against NCDs, I will also want to again remind you that you can give your comments, you can give inputs, you can ask questions from the 2 media platforms. That is the social media account, that is Twitter account. We have the hashtags there. You can also pass through the Zoom and give a question through the chat box. We are also going to give you an opportunity to ask questions, those who are live here. And before I come to the question time, we are going to move a bit faster so that we can give enough time for you. Dr. Francois, there's something related to the implementation by different stakeholders. That's the point of view we are looking at this morning. How are we going to ensure that we have domestic funding that is going to sustain the current or the preliminary plans established by RBC in the fight against NCDs? We need prevention, we need diagnosis, but we also have management and treatment. Some drugs which are going to be available, some of them are very expensive. With the current insurance scheme, do the population have access to these drugs or these medical devices for the self-tests and so on? How are we going to ensure that the domestic facilitation towards the support against the NCDs is possible?
Okay, thank you again. So, as you have seen, our national strategic plan has got a huge funding gap. And also, as you are saying, like, the second objective related to strengthening the health system for early detection and the management of NCDs, I mean, has got 80% of the total cost of our national NCD strategic plan. And if you just say you go deeper, I mean, a big chunk of money will go on medicines, on lab diagnostics, and also many those two areas. And I think the government is doing a lot to make sure that we have those quality medicines, we have patients have access to those quality medicines, have access to those lab diagnostic services. But again, so that's where we need, the WHO country representative has said, and we are even very happy that now there are, I mean, mechanisms that are being put in place to support globally NCD response, because we have the Global Fund for NCDs. I mean, for HIV, malaria, and TB. We've had the PEPFAR also that really has supported a lot of response. We've been aiming to have similar global mechanisms for NCDs, and we hope that this one that is being together, I mean, under the leadership of UN will help a lot our national NCD response. But also we know that we cannot only rely on those external funding. That's why we need also to engage local partners not only private sector, but also other public institutions. So one of the strategies that have to be put in place is to see, we know there are we are even recommending some work that is being done by different pharma companies, putting in place access programs, so that, we can have quality medicines at an affordable price. There are also some other global mechanisms that we know that the FIT NCD partnership is working on marketplace. Interruption. So I was saying there are also those other global initiatives like a marketplace. It's a good initiative that will be putting together different pharma companies so that they can, see how to reduce the price for these life-saving NCD drugs. These are really good initiatives that we need to, to have. How can we work together as the region? How can, as East Africa, and be able even to say that, okay, now Rwanda, Kenya, Tanzania, Burundi, these are the quantities you need for these medicines, for these lab reagents, and then having those considerable volumes, you can be able to approach those pharma companies and be able to discuss or to discuss and have a good price. So these are things, mechanisms things that have to be put in place so that really we can have our people, even NCDs, can have quality but also affordable medicines. Because I can give you an example. When we started this journey of decentralization of NCD management or NCD early detection, I remember back in 2014, we had around 17,000 people with different NCDs that were enrolled in different NCD, services in different health facilities. But as we speak now, we have more than 200,000 people with NCDs taking drugs from different health facilities. But if you look at the prevalence of, let's say, raised blood pressure, raised blood sugar, so let's say now we are at 15% of our people have high blood pressure. And if you, if you put it to the total population, meaning that we should be having around more than 1 million people with high blood pressure that need treatment. And so these are maybe big numbers. And so without having those mechanisms in place, make sure that we have good drugs, cheap drugs, but also make sure that we have some innovative ways of managing these people, because I'm not seeing our health system be able to manage, 1 million people with NCDs coming every month for pharmacy refill for consultation. That's where now we need technology. How can we now start doing e-prescriptions? Do we need every time maybe someone who is already stable, who is, who knows his or her disease, his complications, to come every month to the health facility, and you know that the same health facility is dealing with other diseases? How can that person get that e-prescription and then go to the nearest pharmacy and get drugs? That's where, again, we need to work together with the private sector, technology companies, to make sure that we have those strategies in place. Because otherwise, if you look at the efforts that you are putting in place to early detect, because if you put much efforts in early detection, you should also make sure that treatment services are available. Is our health system alone, if you continue doing the business as usual, be able to accommodate all those people that we are now, detecting early? So that's why we should really think about those innovative ways. How can you have community programs for NCD management? Can we use health posts? Can we use community health workers? How can you work with, these private pharmacies? I think this afternoon we hear from Babir on how they are doing, on how they are helping people with NCDs. So these are maybe, there is no one single strategy that can solve all those issues. We need to combine different strategies to make sure that we can be able to manage where our people with NCDs. Thank you.
Thank you. You've mentioned of health technologies. From the private sector perspective, African Federation, could you please give some overview on how the private sector has been involved towards the fight against NCDs. Do you see the opportunity that the private sector has already optimized or have already taken into account after realizing the current gaps we have?
Thank you very much, moderator. Yes, of course, not to repeat what my predecessors have said about some organizations and companies who have effectively intervened in this fight against NCDs, companies like Bible, but you have others who came up with innovative solutions. Some are coming up with innovative ways of treatment. Some will be also part of this conference, like EPIDU. What needs to be also understood is that private sector has been benefiting, and that's across the continent, from different source of funding as well in specific government programs, including the fight of NCDs. You have structures like Farm Access that are really into innovative technologies. You know, in the region, in East Africa, they are very active. There is different collaborations, public-private collaborations, but also private-private collaborations. You have, you know, Zipline that probably came earlier in discussions and probably will come also in future discussions. But what the pharma industry, which is always among the top 5 industries in the world, has been contributing, and that the WHO representative has alluded to that, is the production of quality products, quality pharmaceutical products, quality medicines, quality consumables and tests. During the pandemics and the several lockdowns, we saw some reorganization of the private sector. Maybe this is not a private health sector initiative, but we saw that we were able to do to have meetings like these ones, not physically. You know, private sector came up with some innovative solutions. So private sector is always on the lookout, and private sector is always ready. And if you look at the numbers, it is 50% of private sector presence in whatever ecosystem you will mention in any given country. When it comes to funding, that's where the difference is. Private sector usually will rely on you know, financial institutions that will come up with sometimes outrageous interest rates, and that is not exactly business prone for the private sector. But one thing that the private sector does that is critical to mention is research. You know, through different organizations, but I'll just mention the pharma spends about 25 to 30% or more of the income into research, and this allows the entire health sphere to be slightly ahead, you know, in terms of fighting diseases nowadays. And the pandemic, if you see, for instance, COVID, how the private sector was quick to come up with vaccines and quick to kind of replenish the gap and the lacks of different commodities that happened due to COVID. But one thing, and quick one, that I need to mention, and COVID was a very good teacher to that, is the disparity of our healthcare systems. We have a healthcare system here in Rwanda that is, if you compare to the region, that is strong. And we will have a need from cross-border, health care, and this is a huge issue because our healthcare system sometimes can't catch up with the demand, and we really need to step this up. We see that there is a strong drive towards medical tourism, bringing it back towards here. But you need now, and this is now the government priority, and this is one of the government priorities, to increase and strengthen the existence of both public and private healthcare facilities, but also train extensively healthcare workers. And when I say healthcare workers, it's not community healthcare workers. It's from medical doctors to the community health workers, and those trainings will determine how ready we are for the next pandemics. And COVID showed us how we had to rely on our own healthcare systems when our borders were closed. No one could travel, and we had to stay and use our healthcare systems.
Thank you. Very good points. You've talked about the medical tourism. Rwanda is attracting visits for cancer control. Now we have Butaro. It's a facility through the government collaboration with the PIH, and it's a very good mechanism. The government is managing NCDs. We also have capacity building that you have mentioned. We need all the healthcare practitioners to be informed and capacitated in terms of knowledge and skills. So, lastly, on the civil society platform, do you find yourself going to take another new initiative to engage NCD fight and management?
Thank you. Civil society organizations have two major roles to play in this journey. Those two roles are advocacy and awareness raising. Regarding advocacy, it is important to recognize that health is political. And NCD, as a part of a broader program, health program, is also political. So civil society organizations have the opportunity to ensure that the political party of NCDs is actually people-centered, based on the needs and perspectives of people living with NCDs, to leave no one behind, that they are context-driven and evidence-based, and they are deserving free of conflict of interest. It is also important to recognize that one characteristic of advocacy is to achieve systematic change. Achieving systematic change by promoting or getting supported to a new policy or a new regulation or a new regulation process, or getting support to evaluate or even to change a policy. That is the role of civil society in this context. Another role is raising awareness. Raising awareness is based on the fact that people living with NCDs has a high understanding of NCD challenges than nobody else. So they have also the moral responsibility to communicate with the communities about those challenges, so that they raise their awareness about NCDs and take preventive measures against the modifiable risk factors that lead to those NCDs. I think this is the two roles of the civil society.
Thank you so much. Very important point, and catching note on advocacy, and even advocacy based on evidence-based studies. This is very, very crucial. So we are coming almost towards the end of the discussion. I'd like just to chop in and see the questions from the Zoom. Someone, can you scroll up? Someone says, I have a question about some health centers which sometimes have NCD medications like antihypertensives and so on. Of possible, directors should have all these as their responsibilities, because people to go to district hospitals is not easy and many choose to go back, hence causing complications. We need to know if anything is being worked on. Otherwise, thank you for the screening. And next question, we are going to take to RBC, accessibility of services related to NCDs medications. People make long distances to get medications. Any other question? Someone says from your CMHS. Okay, do you have any other? Yes, my question is this. This is Sylvia. In rural area, there is totally weak in preventive NCDs and much limitations such as ticket, long distance, and so on. How do you think on that as NCD Alliance? Do you have any other? If we don't have, then we can go. Do you have any question in the Twitter handle? Any question from the Twitter handle? Do we have any? We don't have. Okay. So there's a question related to the distance covered by the patients going to access the medical services, and then let's take three questions from the panel, from the congregation. There's a lady behind there. Yes. Do we have a mic which is moving around? Meanwhile, Dr. Francois, note that question that was asked by the colleague. Yes, the lady on the red blouse. Yes. Quickly. We are remaining with less than 10 minutes. Less than 10 minutes. We need to have at least 2 microphones along the way so that we can move faster. Do we have any other mic? There's a lady behind there where you have just come from. Can you take this? Okay, you said about the multisector collaboration where the Ministry of Health is working together with different organizations to reduce NCDs risk factors. I was wondering if you are also working with the industries that create beverages, food, tobacco in addressing NCDs. If yes, how are you working with those industries? This is going to be handled by my colleague Mutembe. You know that question too, about the involvement of manufacturers and industries in ensuring that the food and beverages are provided to the standard that they can also participate in NCD prevention. Okay, yes, sister, yes, go on.
Okay, thank you very much. My name is Ingabire Emily Jocelyn. I'm a pharmacist. It was a quite insightful panel discussion, and I would like to, without any delay, I would like to ask my question. We're talking about the multisectorial collaboration and the role of different stakeholders towards the reduction of NCDs, be it within the prevention, treatment, and impact mitigation. Now, before asking my question, I would like to give a small quote I like a lot. It says, there is nothing for us without us. So I would like to ask what's being done to engage the community, especially people living with NCDs, people without NCDs, to match the efforts of these different stakeholders. Basically, it's the role of the community, or engagement of the community towards, or to match these efforts.
Thank you. That one will be handled by Dr. Joseph, about the community engagement, and especially these are the beneficiaries. We have a young man here with a red tie, Maybe. Do you have a mic, please? Yes, behind the chairperson.
Okay, thank you. My name is Brandon Yasman. I'm a registered pharmacist. My question is on NCD prevention and detection. So prior to the COVID pandemic, we had the expansion of the Car-Free Day initiative to the secondary urban cities of Rwanda, like Nyagatare, Musanze, Huye, and currently it has restarted in Kigali City, despite having infections lower in those cities that I just mentioned. So my question is, what is RBC and Rwanda NCDA doing to sustain the step that was done before the COVID pandemic, and making sure that we don't go back to where we were? Thank you.
It's a question on NCD sustainability. Thank you. Yes, we have a sister here at the front. We are going to pick only two more questions.
Thank you. I'm Crescence Mukanawana from
Where are you?
Women Organization.
Where are you? We can't see you.
Hello.
Okay, yes, please.
I'm Crescence Mukanawana from Civil Society Organization, especially in women organization, and I'm a winner 2020-21 of award tobacco control. I thank all panelists for their presentation, but I have two questions. Number one is addressed to WHO country director. Another one is addressed to NCD Rwanda. I want to know, I know WHO work with our state through RBC, but I want to know how WHO can support civil society, especially women organizations, to prevent tobacco and NCDs in our country. For NCD Rwanda, when I look at here in this room, I see many men. I want to know how can we consider the gender dimension in this process of NCDs prevention. Thank you very much.
Thank you so much. Lastly here, at the first end here, please. Yes.
Thank you so much, and thank you for organizing this event. So I have two questions. The first one, if I can jump to the proposal from Philippa. Philippa, when he was asking about the awareness, but also about the screening about the cancer. So for me, there was a presentation from Professor Mchumbitsi, so where they were showing us how they are fighting NCDs. But when I was seeing the slides, it's like cancer was not there. It was there, but I'm going to explain much more.
Can you
it was
straight to the point?
Yeah, it was about the Mutuelle de Santé, where they were saying that Mutuelle de Santé now is covering about the treatment, about the screening. But for the cancer, I thought that we were going to have someone from Mutuelle de Santé. Now we have an announcement for all the public hospitals that they are no longer going to cover the treatment for patients having cancer. So for me, if I'm having like breast cancer, better to know when I'm going to have a solution. Mieux vaut savoir si on a le traitement, mais mieux ne pas savoir si je ne vais pas avoir le traitement. Better to know that I'm having the disease, but I'm going to receive the treatment. So, but if I'm not going to receive the treatment, better not to know. Yeah, so that was also that question for me. I don't know who's going to respond for Mutuelle de Santé. Why?
Yeah, we shall have to maybe from Dr.
Why cancer is no longer on the disease that they are treating. So another point was concerned WHO. So really you have done a good work about the tobacco. Now we are not having the sponsorship from the tobacco companies, no marketing, you have just banning. But there's something concerning alcohol. So alcohol for me, it's like the stakeholders, the one concerned, they are doing nothing. For example, I have been pregnant twice. I've visited a lot of gynecologists. No one has told me not to drink the alcohol. And we know that we are having kids, young kids, facing the fetal syndrome alcohol. So it's like, you know, you can drink, but with the responsibility. So even if one glass of wine can harm a kid, so what is the range when you are saying drink responsibly? How? So for me, I think that for the alcohol, it's something many people, all here, I think that from our family, we just have a member, 1 or 2 or 3 that are facing that issue. But still, we are seeing a lot of sponsorship, a lot of marketing, a lot of things going behind alcohol. It's like people are normalizing being addicted to alcohol. So I think that for WHO, something has to be done, and quickly, without just waiting 10 or 20 years. So thank you so much.
Thank you so much. Time is not with us. Someone is persuading so much. Let me give only last chance here so that we go to the panel and we summarize the questions, responses. Please, from this first end seat, introduce yourself and the question.
My name is Dr. Julius. I come from AHF. My questions are related on high-end trainings that are need for people who take part in treatment. You find the facilitation around that is kind of normal, equal to someone doing undergraduates. That side makes it so hard for people to go into this high-end specialization that will come and have higher returns on investment. And another concern is also innovations. Innovation, maybe it goes to WHO and our pharmacists. The new innovations that may come up are kind of taken equal in terms of regulations. There is no clear framework for, say, herbal products locally made for that site which needs to be promoted. If you have to have treatment that is novel but more effective, the regulation side, the framework, needs to go beyond the normal to tackle the new things that may come up in the market. The other concern is also about the diagnosis and the monitoring.
Kindly summarize.
Yes, this is the last.
Okay.
Diagnosis modalities around the NCDs is also high-end, needs a more intentional investment in diagnostic modalities that governments, organizations need to support the facilities, the healthcare facilities, to be able to doing that. Thank you.
Thank you so much. Let's go to the panelists for quick responses. We are going to have very short responses, less than 2 minutes, if possible, from each panelist. From the RBC, someone mentioned about the distance covered by the patients when they're looking for healthcare services. Also, someone also mentioned, he just mentioned about the regulations regarding the accessibility of medical products like herbal medicine and so on. Can you kindly respond? And any other questions that you captured from the audience related to your docket?
Thank you so much. And it's a valid question. So when you started the decentralization of NCD management from, specialized facilities up to the level of community health facilities, so we have been really seeing an increase in number of people being treated, but also good treatment outcomes. You know, we've been saying that the cost of transportation is much, much bigger than the cost of the healthcare itself. If you take, someone doing, let's say, 20 kilometers from his or her home to the health facility to get drugs, and sometimes there is no public transportation, she or he will pay around even more than 20,000 Rwandan francs to go and pay 200 as ticket moderateur at the health facility to get the medications. So, and that one was not acceptable. That's why we took a decision to move down there closer to the community at the health center level, where we can, where even people can travel on foot and go and get their medications. And even the COVID-19 has shown us that really with these travel restrictions, it was not going to be possible now to have everybody coming at the district hospital for pharmacy refill. So we are happy that now all health centers now, they can be able to treat these at least simple NCDs. But of course, while decentralizing NCDs, we should do it carefully. You cannot allow, those primary health care facilities to treat everything. There are those more specialized NCDs like cancer. We are not seeing a health center, this hospital be able to provide the cancer drugs, but they can treat hypertension, they can treat diabetes type 2, they can treat asthma. So we are happy that now services are available closer to the community, but now working on improving the supply chain to make sure that at least those medicines are always available at the health facility level. So we know that we still have some bottlenecks that we have to work on to make sure that there is no, facilities have a stock out, and we think that it's a journey and we should continue working on it. So, but now we are happy that now services are closer to our people. And the other one on Mutuelle de Santé covering cancer services. This is, since I joined the cancer program, I think like 6 years ago, this issue was there, but and again, it's still there. So we remember our community health insurance scheme, it's still vulnerable. And it's even still struggling to cover those basic things, infectious diseases, maybe pneumonia in children and so on. And then when it was established, it was not meant really to cover these highly specialized services. But now it's a reality. People need it because now services are available and the people need to have access to them. So we are happy that now, and again, through the discussions that we were having with RSSB, that is managing this community health-based insurance scheme, so they are now willing to go there, to start supporting. But of course, we are really now optimistic that, the Ministry of Health and also, RSSB and also other health insurances, we are now working on a new package of health benefit, on a new package of health benefits. So, and then there will also be cancer services in that package, but we not really everything, but at least the first line of treatment, so should be now, will be covered by the health, the community health insurance. But what about those that are the second line, the third line? That's where we need those access programs, having pharma companies supporting, to make sure that someone who is failing the first line can really have options for the second line. And then this will be done gradually. And also to be able to do that, that's why even recently RSSB issued that a communique about stopping the prescription of cancer drugs because it was not really done in a good way. So, so to be able to do that, we need to have national guidelines and protocols so that we can treat in a harmonized way. Because we don't want each clinician to write what he wants, but make sure that we have those drugs, and then happy that now we have a guidance from the WHO. Now there is essentialist of medicines for cancer. These are the medicines that now should now be covered by our health insurance. So, and we know that it has delayed, but now we are very optimistic that now with the new package of services, cancer services will also be included. I think these are the two. Maybe my colleagues can also take other questions. Thank you.
Thank you so much, Doctor. Let me go to the WHO Country Director. Someone asked about the involvement or the support to the civil society, especially the women organization in the fight against NCDs. And also someone also mentioned about the content of the marketing done by the companies like tobacco through the mass media platforms. Are we able to regulate and ensure that this is strictly adhered to? Kindly respond.
Thank you very much, moderator, and thanks for those questions. I think I will quickly answer to the question on tobacco. So again, congratulations for winning this. I mean, this was only a few countries, 7 countries in Africa that got this prize. So well done. And I think it was very good to see that this is work from civil society right on the ground, and well done. I think in terms of the support that we provide as WHO, as you know, we work through partners. We work with RBC, with government, in terms of building capacity, in supporting organizations in all interventions, including tobacco control. But one of the things that we are doing more of now is to work with partners beyond government. And of course, the whole tobacco interventions, it's become very clear that just working with the Ministry of Health doesn't really work. You need to work through other partners. And that's why working, for example, with the NCD Alliance is critical for us, and it's something that we'll do more of. But also we are beginning to engage more with civil society in providing support with to non-state actors. So you will see that as time goes, we will engage more. But of course, we still largely work and coordinate and support government to be able to provide this support. So things like capacity building, yes, we're not a big funding agency, but we do provide some seed funding for very specific things, especially advocacy and capacity building, and also some specific interventions at local level. So we are changing the way we are working a bit more and beginning to engage with partners outside government. With regards to alcohol, yes, it's true. We have made very good progress with tobacco. Of course, like I mentioned, we're still not there. There are still gaps. But in areas like alcohol, we have had much more challenges. Part of them, of course, relate to the networks themselves. With the good progress that was made with tobacco, we actually ended up with some of these organizations learning to be more effective in avoiding the censure. So we need at the local level, one, to learn from the work that we've done with tobacco. It's not really about WHO doing it. WHO provides the technical guidance, we provide the technical support, we build capacity to be able to do these things, we help with monitoring. But it's the national strategies, it's the implementation of those strategies, and the interventions. We have already agreed on the best buys with regards to alcohol, just like we have in the other areas. The key thing is, how do we make sure those are implemented? And that's where we talked about the multisectoral coordination mechanism, which needs to really be monitoring how well we are doing, with the support, of course, of WHO. But making sure that there's local action. And local action means ensuring that the different sectors are fully involved. We're talking about education, we're talking about all the other sectors. We're talking about civil society, we're talking about private sector, and making sure that everybody is actually doing their part and monitoring this over time. So all of us need to do more in the other areas, particularly with alcohol, and as WHO, we're doing more to work with governments. But the real critical thing is to make sure that the plans that we have developed, which are very good, for example, for Rwanda, really get implemented. We get local action with regards to alcohol. Then we will begin to make progress. Maybe the last point I just want to make, it's also important that we have adequate information on the risk factors. We heard, for example, about tobacco, but the other areas we don't have enough information. We need to know exactly where we are with regards to these programs. So WHO is currently working with RBC, with Ministry of Health, to conduct what we call a step survey, which will, because we last had a step survey a long, long time ago, so that we have adequate information on the risk factors, on where we are with these different areas, and how well our programs doing. For example, really, how are we doing with, we already heard from Dr. Francois about the people who have diabetes or who will have diabetes. We don't have a lot of data, real data, we have estimates. So the STEP survey will help us to look in some of these programs so that we have more information that will guide our response even better. So that's one area that WHO is working to make sure we have the information to be able to improve our programs and know where we are and address them. Thank you, Chair.
Thank you so much. Can we go to the, how are we going to involve the community now from the civil society perspective? How are we going to involve the community in ensuring that we fight NCDs?
The way to engage the community, the entry point will be telling story of self, telling story of us, and telling story of now. Story of us is telling the challenges faced by a person living with NCDs, when he reports his challenges, and reporting his challenges encourage others to tell their stories, and then story of us give an opportunity to see shared challenges and a possible choice to do to overcome the challenges. Now the story of now is the urgent action to be taken. Linking story of self to story of us and story of now frame a public narrative on NCDs. When we can see that there are a commonality on risk factors among different NCDs, that there are cross-cutting solutions among different NCDs, then we come together to drive a change as a movement, not as a single individual. If we come together as a movement of NCDs, we have a lot of chance to be heard by multisectoral stakeholders.
Thank you so much. And lastly, Mr. Mutembe, someone mentioned about the innovation in the health sector, the health technologies, how we're going to ensure that investments are coming. You mentioned about private partnerships, but also come to this context on capacity building. Someone also said that how we're going to have high-end trainings to ensure that the health care providers get these trainings accessibly, and how we're going to have innovation in the industrial sector to be able to produce medications that are going to be accessible by many, which is cost-effective and safe.
Thank you very much. Those are very good and important questions. Innovation is a word that will keep coming, throughout the years, and training as well, because as we develop our health systems, you will need to train the healthcare personnel. I'll just jump quickly into the traditional, the alternative medicine, herbal treatment. This is a sector that's growing, and it's growing fast. In Rwanda, though, there are regulations like everywhere else, and like in any sector or any production sector, you need to have some standards. And our local producers are trying to keep up with the standards, still finding a few challenges, especially in financing. But this is really where it's going, and they have to up their ways of doing their production and the ways of presenting their formulations, whether it's capsules or suspensions, etc. And of course, they have to follow standards. We have regulators, the Rwanda Food and Drug Authority, and the same Rwanda Food and Drug Authority will look at their registration of those products, and of course they'll have again to follow a certain number of standards. But what I can say is, with what is happening and what will be happening from next year onwards, there will be a strong drive into production, and of course, as you start producing locally, you training, and then you have a new set of skills. You improve the local knowledge through, of course, at the first few years, an importation of skill set, but then, of course, skills are improved ultimately. Quickly into the beverage and tobacco, it has been tackled earlier, but Rwanda is a highly, I'm trying to avoid the word strongly regulated country, but it's a highly regulated country. You will all remember when a tweet came out regarding shisha, and shisha was banned in Rwanda. When it comes to alcohol and tobacco, these are, and of course, I will try to measure my words. These are very huge industries, and they contribute dramatically to our economies. They are the top taxpayers, I'll put it that way. But again, they are subjected to the same regulators, and they're subjected to certain, abiding to standards. They are subjected to restrictions. In Rwanda, it's not like in some countries where you go in closed areas and then you find people smoking, for instance. And of course, the numerous controls, have brought down, for instance, the rate of drunken driving and etc. So those are the few things I wanted to mention. And lastly and quickly, there are initiatives. For instance, in East Africa, the East Africa Healthcare Federation was involved in a study with the Africa Economic and Consortium, research consortium, regarding COVID and best practices around the region. And in phase 2, we'll have the NCD as a critical topic, and it's good to have these exchanges in the region and shared best practices. And this, of course, start a conversation, engage governments into, including, the private sector in building these policies, and of course, including all the stakeholders, including the manufacturers of tobacco and beverages. Thank you.
Thank you so much for the panelists. Lastly, there is a concern which was raised to the chairperson of Rwanda NCD Alliance. Can we have the mic there to him? Kindly. Let me give him mine, please. Someone mentioned about gender sensitivity.
Thank you very much. So I would like to take some practical things from this panel. Danny, in other countries, pharmacies play a very big role in terms of ensuring compliance of people living with NCDs, with medications, with treatment, in even ensuring some tests like INR or blood sugar. And that's something we have not yet started talking about in Rwanda. So as the head of the organization in Rwanda, do you think it should be possible? And if yes, can we have a commitment so that we can start such discussions, of course with RBC, to see the feasibility of such a move to support people living with NCDs? The other thing I wanted to mention is that I liked very much the WHO representative whole of society approach. And one of our members suggested that we have not yet tapped into collaboration of churches and religious organizations. And elsewhere, they play a role in education. For NCDs, they can play a role even in raising awareness. Do you think it is something possible? And if yes, could we also start an approach and a conversation? Thank you.
Thank you very much. I really thank the chairperson of the NCD Alliance. The good thing, and we're talking about PPP earlier, and Rwanda is one of the countries that involves the private sector in the advisory of public institutions. I am part of the Rwanda Biomedical Board, and one of the discussions, of course, that has come constantly is the involvement of pharmacies in different government public priorities. One of the things that have been achieved so far is, and again in collaboration with the RBC, is that the pharmacies are allowed now in providing family planning injections. This is a huge step forward. And of course, you realize that pharmacies have a certain level of knowledge in healthcare providing. They have a certain knowledge in the existing ecosystem of healthcare, and of course they have a direct impact in their communities. They are usually considered as the last line of defense between the medicine and the patient. These are the last people who actually give their advice, the piece of advice to patients. One thing that also has been discussed, and I mentioned it quickly earlier, is that pharmacists and pharmacies, in pharmacies, and in pharmacies you don't only have pharmacists, you also have other dispensers, like for instance nurses. But these health person will intervene in the near future in vaccines, and we've seen that. And this is really where now we really look forward, and that's really a commitment to having more engagement of pharmacies and pharmacists. More than what we have, for instance, with prescribing medical doctors who on a daily basis have phone calls and we have visits and this is already an existing dialogue, an existing exchange. With the Rwanda Healthcare Federation being an umbrella of these associations, we have even more dialogues between these different sectors. Now, the conferences are really a good place to have these discussions going. But like you said, Chairperson, we really have to move forward, and we have to at some point stop with the blah 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 and move forward into quick actions. And I think Rwanda has shown a great maturity in promoting such discussions and promoting healthcare provision in pharmacies. So we're really looking forward to see next year being even more engaging and producing more results than the previous 2 years, which were crippled by the pandemic. Thank you.
Thank you so much. The discussion has been very good and elaborative. I think from the resolutions that you have made so far, and we believe that by the end of the training we shall have a clear roadmap on the way forward on how we are going to take into actions of our commitments. We thank you, Rwanda NCD Alliance, for organizing such an event. I thank you for the panels, the panelists who have devoted their time and make spontaneous contributions towards the fight against NCDs and UHC. I want to end and run from there, and let's give a very big round of applause to the panelists as they take back their seats and they take back the programmer. Thank you so much.
Thank you so much for fruitful discussions we had on this panel. We are coming to the before noon sessions to the end. We're about to go for the lunch break, but we do have like few communiques.
Yes. I think the conversation was much too interesting, and now lunch is cold. So unfortunately, we will have to eat really quickly, and we have about 40 minutes of lunch break. There's ladies there that will provide you with lunch coupons for those who don't have them. and they'll direct you to the restaurant hall, which is downstairs. And we'll be back here at 1. It's now 6 minutes past 1, so we'll be back here at 50 minutes past 1 exactly. We have a few communiques. One is that there's an ambulance available on standby, provided by WIWO. If anyone has a medical emergency, just so you know you're safe. There's someone who has lost their eyeglasses. They're deep blue, so if anyone has found them on the table, please get them to someone in Umushanana and they'll be able to help. So please, let's all head back downstairs to the restaurant and be back here in 45 minutes. Enjoy.
The last thing, if you didn't put your name on the attendance list, please make sure you do that. And enjoy your lunch.
Co-infection, also aging. So meaning, even if it was, I mean, like they are living in our population, also they have to face problems like other people are facing, including the risk of having NCDs. Traditional risk factors for cardiovascular diseases like diabetes, hypertension, hyperlipidemia, smoking also exist in HIV. So much as non-infectious people have NCDs, also HIV, they have, if I can say, more burden of HIV and NCDs like others. 50 to 100% increase in risk of CVDs even after controlling these factors. So because they are aging, so hypertension and other cardiovascular disease-related risks come in HIV population. So we need to do integration. Next. So HIV and some antiretroviral therapy risk factors, that one said. All people living with HIV should be screened for NCDs. And also should be taught about the risk factors like tobacco, obesity, physical activity, and anxiety. So next, yes. So WHO recommends assessment for major NCDs and comorbidity at HIV diagnosis or initiation of ILT. Meaning that somebody who has HIV, during assessment, during diagnosis, during provision of medicine, we should remember that they may be having NCDs and then be treated, because we are having, like, somebody gets appointment today for NCDs medicine, then after 15 days comes for HIV medicine. That one is also giving a burden to our people, so we need to do some kind of integration. Next. So like we do, they need to have lifestyle modification like others. They also recommended for all patients to prevent NCDs and should be integrated into routine HIV care and treatment. Next. Yeah, this is some of the things that the health behavior that should engage, like for education. They should engage in regular physical activities, eat healthy diet as others, as it is recommended for others. Low and saturated fat, tobacco use, attend regular follow-up for physical activities, engage in moderate levels of physical activities as like is recommended for others. So that's also for physical activities. Let's go because we have less time. Yeah, tobacco as well is another risk factor that can also affect HIV patients, and also use of alcohol and health diet. Those are some of the recommendations that are given for us to manage HIV patients, as they are also susceptible to having non-communicable diseases. Next. Okay, that's to the level of adherence. We need to teach these people nowadays what we call people having so many medicine. They need to be educated. Like somebody is having diabetes, has hypertension, is co-infected with HIV. So this person is really vulnerable, that we have to care about him or her. So teaching him about adherence measures is very paramount, I think. Next. Okay. See, I was running like that person. So I go next. Okay. Quickly. Okay, thank you. It's not like we are trying to see, during the outbreak of COVID, more than 90% of our patients who died were NCDs, and they had NCDs. So that one brought us to thinking that also raising awareness on these comorbidities is very important. Next. So we have those risk factors. At least this is a song that we normally talk about, where diabetes, cancer, chronic respiratory disease, then cardiovascular disease, also other NCDs. So some of the risk factors we have to talk about are physical inactivity, obesity, tobacco use, harmful use of alcohol, unhealthy diet, and malnutrition. Maybe with the exception of malnutrition, which comes due to maybe malnutrition in terms of deficiency. The rest of the problems there, it's just the normal life that you are living. Physical activity, smoking, alcohol use, like that. Those are some of the things we need to take just to change our mindset and then revert the trend of NCDs. Next. So severe acute respiratory syndrome, that is COVID, what is, the way they explain it, it is a causative agent of coronavirus, that's COVID-19, was declared in 2019, but in Rwanda it was 11th March 2020. The treatment guidelines for COVID-19 vary between countries. Of course, when this pandemic came, we did not know about COVID, so countries were treating according to their own way. We had Tanzania that would use some kind of sauna-related guideline. We had Rwanda that was trying to do measures of prevention. So, but as time went on, we had to improvise some kind of prevention and treatment as well. Next. So, the COVID-19 and NCDs combined management approach. NCDs such as cardiovascular diabetes, cancer, and the coagulation disorder were so much influenced by the COVID. So they are interlocked condition. This comes because, let me talk about this one. We thought when COVID started, we thought it is a respiratory condition. But little knowing that when somebody is having diabetes, hypertension, and other NCDs, is having some kind of inflammation, a multi-organ inflammation for a long time. So, and then this time, COVID does the same. And that's why maybe some of the people that have NCDs and COVID, it becomes worse because they all affect the organs almost in the same approach. Like, I don't need to go into physiopathology, but they influence each other. Next. So, as I told you, COVID can create injuries, multi-organ injuries, including lung injury, kidney injury, cardiac heart injury, liver dysfunction, and pneumothorax. Next. So, these are some of the, I tried to do some of the reviews of the papers that were written. We have like cardiovascular, when somebody has COVID and he has cardiovascular, then the comorbidity is related to cardiovascular is 10%, then diabetes around 7%, chronic respiratory disease 6.3%, systemic hypertension 6.6%, and then cancer. And this is why you found that when people had the COVID and so you would find that because of lack of specialized services, some people would even die without us knowing what could be the problem. But take an example of coagulopathy. If you have the problem of coagulation of blood, you can't just know because our facilities cannot do all that kind of quick assessment of coagulation, and also the specialties, the specialized services are limited. Next. So the most common presenting features like fever, cough, dyspnea, then muscle problems and fatigue, then sore throats, nasal congestion, headache and nausea, then vomiting with diarrhea. We had so many cases of COVID that presented with severe diarrhea. If you had imaging of somebody who had COVID in the intestines, they just present like some flesh meat that has taken like more days when it started rotting. That's the problem with the COVID. So diarrhea was a problem. It affects the digestive system severely. Next. So this is some of the interventions that we did when we started having so many cases. We had to do low priority, high priority, and high priority, meaning like if somebody had mild presentations, should be treated at home. Then moderate priority should seek care in the hospital, but also can do outpatient. But next for severe, that's when we would go for intensive care unit, and that presents like that. So I'm not trying to go into details because we have less time, but we admitted patients depending on the severity of their presentation. Next. So it is imperative to recognize these susceptible groups rather. Like we need to know that somebody who has NCDs it's a problem if he contracted COVID-19. We have to educate them, treat such patients multidisciplinary approach. No, it needs multidisciplinary approach to manage somebody with COVID because you don't know which organ is going to be most affected. Like when we talk about heart injury or lung injury, so it means we should be having different specialties to tackle that problem also. Avoid unwanted performance and adverse drug interaction. Of course, somebody is having several conditions. You think about giving medicine, but sometimes drugs, there is a problem of drug interaction. Consider post-COVID follow-up. We have seen people who after like even 5 months, they can get late complication and then even they die. We have had cases of people who get COVID, who think they have recovered COVID, but sometimes they have got like heart injury, lung injury, they go home. After some months, they go back to the hospital and even maybe they die. So we need to think about lifestyle change. So risk of very severe COVID-19 disease varies and depends on age, sex, presence of comorbidities, that's chronic diseases. So those are some of the influencing factors. Age, sex, and comorbidities were the most influencing factors in terms of loss of lives that we had in this country, even elsewhere. So this evaluation should be considered in targeting prevention strategies in management of prevention and management of COVID holistically. Next. So I think I'm getting to the. So. Thank you for your attention. It was like, they told me to use 15, but I have tried to cheat 1 minute. Okay, thank you.
A round of applause for the presenter. So I'm going to receive the second presentation. It will be around integration of NCDs and HIV services. And the presenter is a director of AHF Rwanda, holds a master's in epidemiology, a certified project management professional from Project Management Institute of USA. He has over 17 years of experience in HIV and highly infectious diseases management. A round of applause to Dr. Julius Kamwesige. Doctor, you have less than 10 minutes so that we can get a question and answer panel. Thank you.
Thank you very much, moderator. Much of my work is taken by colleague Dr. Everest. Mine is just to take you through what HIV NCD integration is like in our health facility setting. Taking an example of a health center, a basic health center setting in our country. Next. Maybe just to highlight that we all know that NCDs, or particularly hypertension. Next. Hypertension is one of the leading causes of morbidity around the globe. And we are doing this, why? Because in 2011, UN declares that HIV NCD integration is a kind of mandate, and we all need to adopt that. WHO also recommended that countries adopted the same approach. Why is it interrelated? There is a predisposing factors around the atherosclerosis that leads to hypertension. There is an oxidative stress and depression that also goes to lead to NCD. I mean, if you have HIV. There are drugs that by themselves have an impact on some of the diabetic mellitus. D40 is associated, even if it is taken off our programs, but most patients who took the drug, even now, might have the effects of fat redistribution issues. And also, there is HIV-related renal conditions. And also, some drugs are related with renal conditions related to clearance, renal clearance. All those reasons brings the reason why when you are dealing with HIV, you also, at the same time, have to have the knowledge, have to deal with the non-communicable diseases. Next. This is just to show how the basically integration takes place, say, a provider level. In our medical files, we have at least at every clinical visit, the guidelines are clear. You have to screen for NCDs mentioned all over across. Still, it has a register that you screen for, of course, NCDs, I mean blood pressure, all those basic signs. And I'm not going to see what you ask in diabetes, in cancers, in breast and cervical, and also in cardiovascular diseases. But get to know that this service provider, if he's informed, if he's used to, will take the details of what needs to be done. Next. Normally what is done at the health facility setup, when the healthcare provider who is maybe an HIV nurse sees a patient, which is done normally on the clinical visits. For you, some of you who may not be familiar with the guidelines, the clinical visits are done currently in the DSDM model. Those who are non-stable can be seen at the end of each month or sometimes 3 months, but even those ones who have suppressed and they are not in some particular category can be seen after 6 months. So every after clinical visit, the patient is screened of the NCDs. And when they see this case, with any of the signs, because our healthcare providers are not very familiar with all I have said should be known, which I will present in challenges, they transfer this case to NCD clinic, which is somewhere, another room or another setup, they are transferred. That means there is a process. Some can get lost on the move, or even they may not also have the knowledge around the also HIV management. I mean, when they go to NCD clinic. Dedicated staff is there to receive the NCD cases, and also who has HIV, but you may not tell. I present it as a data issue as well in my next slide. HIV clinic nurses screen for different NCD, as I said, including what they have, the rest of us have known. Next. This is a register which you can see in the NCD room. There is no way how you can know that this patient is HIV positive. So that means if the healthcare provider in the NCD corner sees a patient, you cannot have the data how many, for example, are HIV infected. So there is a gap to be filled in that side. Basically, it's like any other register which is seen in outpatient. So that is something that should be taken over note. Next. Yeah, as I said, I think the rest of it was done by my colleague. Mine is to present the mostly what gaps do we need to fill in to make an effective management integration of NCD and HIV. Insufficient data, maybe I guess the people who developed the guidelines were asking if we put HIV positive, would it have issues around the confidentiality, disclosure, things of the sort, but that needs to be aired out. There is no data and collecting tools that indicates a patient is HIV. You're lacking to know who is co-infected for any disease according to the register seen. Neither is hard. Also, when you check in the electronic medical records or HMIS, you cannot tell this patient if he's diabetic and is also HIV positive. So all those data related issues needs to be looked into and be addressed. Also, there is a lot seen in the terms of stock out of reagents at the health facility level. My colleague pharmacists in the supply chain, there is a need of a gap to be filled around those ends. Reagents around the cervical cancer screening, reagents around the glycometers, all those that are needed to use for screening of NCDs. There is also insufficient equipment like glucomic machines and not easy to detect thereafter. The glycated hemoglobin is only taken at the district health facility. It's not at the health center level. All those are things that we need to look into and address. Next. Yeah. The other observation in terms of the gap is the lack of HIV screening tool in the NCD for HIV case. As we have seen, you can in the file we are able to see the NCD for the file of HIV infected patient, but in the NCD they are not able to screen for HIV, or they are not mandated. If they can, of course we know it's a provider-initiated testing. They are not prohibited, but I mean we need to emphasize, to put a note that they also need to take a note of screening for HIV. The skills for treating NCDs are lacking for the in charge of HIV patients. I mean they lack some particular highly advanced skills that would be needed in treating the NCDs. So that has to be addressed. Lack of basic tools for use at HIV clinic, like BP machines. Sometimes some clinic facilities may lack even these basic ones. But in the case of NCD, we need some more advanced more enforcement, more investment. And that keeps doing it more and more again, so that when the broken ones are over, we are able to replenish or to repress. This one, I would say, glycemic reagents are not also included in the programmatic activities. Program activities, mainly these are given by the Global Fund and other funding organizations. So you find they don't buy them. But some of the NCD reagents are not included in the program for free at the health facility level. So that causes more burden for the health facility to buy by using their own money, which may not take into a big consideration. Next. Yeah, maybe as a part of way forward, I kindly said trainings, intensive more trainings should be given the task shifting nurses, availing the machinery and the medicine like salbutamol spray, because they may be stock out around that, sufficient equipments, and also importantly, which calls for the stakeholders now, is the sufficient funding. So funding is lacking and needs to be put enough, and this has to be continuous in order for what our colleague, Dr. Francois, has said, to implement the strategic plan. There is a need of funding and continuous follow-up and mentorship for us to achieve what we said we need to achieve in the next 5 years. Next. Yeah, thank you. That was just a brief summary of how we needed to know how the service delivery is done at our health facility setup. Thank you very much.
We have a slight change on the agenda. We have the third presenter. Allow me to receive Valentine to come forward and make a presentation for 5 minutes. 5 minutes, and then we go to the key question and answers session. Francine? Valentine? Okay.
Good afternoon. Briefly, I would like to introduce a little bit about what I'm going to present. I am Valentina Dushimimana. I work at the RBC in the Research and Innovation and Data Science Division. We are conducting a study on health determinant for major non-communicable disease in people living with HIV. When we said major non-communicable disease, we talk about cardiovascular disease, diabetes, and cancer. Briefly, we will talk about the hypertension, which is mainly major risk factors for cardiovascular disease and other non-communicable disease. At the time I'm waiting for they put slide, I can say that at the time of enrollment of the participant, we asked the participant if they have any NCDs, because their condition to be enrolled was not having any NCDs. There were some who told us that they have NCDs, but there were others who have it, but without aware. Those are the number that I'm going to show. How we find them, we call them then at the time of their appointment, we screen them. We can say that it's a final because you can't confirm that someone has hypertension doing only one screening. The data collectors try to do many times, then we link them to NCD clinic for confirmation and further management. Next, please. The outline, we talk about background, problems, and purpose and belief about the findings. Next. Globally, NCDs are the first leading cause of mortality like cardiovascular disease. Next. Next. As I said that I'm going to focus on hypertension. Hypertension is a silent killer. So that's the reason why I'm focusing on it. The purpose of the study I'm going to present, we were based on presenting the prevalence of hypertension and checking the associated factors. In the major finding, where the enrolled participant, as I said, that is in people living with HIV, we enrolled also a small group for comparison and another group for newly diagnosed HIV positive. Briefly, among the enrolled participants, the more aged group were 35 to 45 years. Next. We find that the prevalence of hypertension was 10.65 among the enrolled participants and was 5 times compared to the HIV negative. This is for the people living with HIV, and this was similar to the findings of a study conducted in Maryland, where they find that hypertension in adults were 3 times compared to the HIV participant. Next. Among the risk factors, we assessed more, but here we are presenting the BMI only, where we found that among the HIV positive, BMI was 18% were overweight, which is also 3.8 times compared to the HIV negative who were enrolled in the study. The findings also are similar to another study conducted in Uganda, where they find that as we increase in age and also the body mass index is among the risk factors. Briefly, when we are growing up, like as we are becoming aged, we are exposed to hypertension and the other cardiovascular disease. To conclude, hypertension is common among the people living with HIV and remain an important comorbidity for the people living with HIV. And there is a need of an adequate screening and management of hypertension. We can recommend that research examining the development of hypertension and associated factors in the people living with HIV are recommended to optimize the management of that dual condition, and also future research to determine the cost-effective intervention to reduce the burden of hypertension in people living with HIV is also required. I acknowledge those who participated in the study and also RBC for supporting us and funders, and also I can also appreciate NCDs Alliance for their regular support. Thank you for your kind attention.
As we move forward, I would like to welcome all the presenters to join me here. I wanted to get, first of all, as I was saying, we had enough time to hear from the presenters. And we had a challenge in the morning whereby we had a lot of questions coming from the audience, but we couldn't pick the questions. I would like to give you the time first to ask your questions, and then if we still have time, I might go and ask my questions as well. I would like to pick questions from the audience and online, if you have questions. Do we have questions here? Okay, we have 2 questions there. Give them a microphone. Try to be brief, be concise on the questions, and then...
Thank you so much. I'm Tumwine John, a student from the University of Rwanda. My first question goes to Dr. Julius Kamwesiga. He talked about the HMIS and the EHR system. So what challenges are being faced in linking all the healthcare settings in Rwanda, in that people can easily access the healthcare, most especially these ones with NCDs and HIV. When a patient with HIV is in another district, different from where he or she dwells, in most cases they get challenges while seeking the treatment or those ARVs. And we witnessed that in during the COVID, when there was lockdown. The other question is about the NCD protocols. Of recent, they developed a protocol for the severe acute malnutrition, but it's still challenging that most people don't have more access to the protocols for the NCDs. Like, most people use protocols from different countries, like Europe and some other continents, which is a bit challenging because they don't have the same food varieties just like we do here. Maybe the East African NCD Alliance and other health stakeholders can help us so that we can get the protocols for different NCDs. We have the Diabetes Association. They can help us with the diabetes protocol. It's still a problem. Those are my questions. Thank you.
Next, please.
Thank you. My name is Arenda Gishimana Benwa. I'm a final student. I'm a final year student at the University of Rwanda in Human Nutrition and Dietetics. I would like to ask the first presenter about NCD prevention and management. More presenters likely to talk about the NCDs prevention and management and the tackle on about diets, healthy foods. But always I like to ask myself those questions. What the government of Rwanda do to address the problems of foods that are produced by the different sectors, like industry sectors and the agriculture sectors. I can give an example in the sectors of agriculture. If people are producing foods, like those who are using pesticide, insecticide, and those people are also later consumed by the population. They don't get some guidelines or they don't know effect of those food are consuming. So about the industrial sectors are producing the more food that are salty, fatty food and the sugar food on the market. When you enter to the supermarket, you like to get more variety of food like a sugar food, fatty food. Those food are are the main causes of those obesity, hypertension, and different NCDs. So what's another thing, when you are moving along the market or the supermarkets, you don't get different place that sells those vegetables and fruit, which are the main purpose of preventing or management of those NCDs. What the government of Rwanda and other NCDs and the other multisectoral collaboration working to address those issues to help the population to get healthy food, because they could be knowing that they can eat healthy food, but the process of those food, they have those problems that can affect their health. Thank you.
Do we still have more questions? We still have more. Let's take like 3 questions and then we give the microphone to the panelists.
Thank you very much. My name is Ishimi Alliance, and I wanted to ask any of the panelists if they could, is there a way, when they're giving out medications of HIV, are there any medications of hypertension that might have negative interactions with the medication of HIV? And if there is those medications that might have negative interactions, are the people dispensing those medications aware of that problem? And my second question comes to the adherence and compliance of taking medicines when it comes to patients living with both HIV and any NCD. How do you track that? Because I guess when someone is taking more than 3 pills or medications a day, compliance and adherence becomes a problem. So how does healthcare providers or any other person involved in the process of dispensing the medicine ensure that the patient is taking the medications as they should? And my last question, and it's a concern, if hypertension or NCDs can be treated at a lower level at healthcare posts, as you have mentioned, but the line, when someone has to change the line from the first line to the second line when they are on HIV, are there any research or any written guidance when it comes to medications that they shouldn't be taking together? Thank you.
Thank you very much. My name is Christophe. I'm addressing my question to Valentin. And thank you for your presentation on the study of health determinant for major NCDs among people living with HIV in Rwanda. It was interesting, and maybe I'm very much curious. So I would like to know the type of population on which your research was conducted, and because maybe there are major risk factors of developing hypertension or BMI, and of course it depends mostly on the life size of people, and also considering the genetic factors. So maybe, if possible, can you tell us the attributable risk of the developing hypertension and the BMI to HIV positive people? Thank you very much.
Last question, and we go back to the panelists.
Thank you. My name is Peter from Africa Medical Supplier. Thank you for this event, and thank you for the presentation of Dr. Julius. I have a comment, not a question. He said there is a lack of some product or some items which can be used for NCDs. And also another overview he gave us. About my comment, we, Africa Medical Supply, we tried to contribute on NCDs. Like when we go for diabetes, we have tried to overcome a stock out of some of strips. I don't say the name, but for last 3 years, we tried to overcome the stock out. And also for hypertension, we are in partnership with one manufacturer. We have presented the figures of hypertension people we have, even NCD project. Then he gave us a discount on
Would you please
BP
go straight
machines.
to the question? Straight to the question.
So, for diabetes, hypertension, fitness, and respiratory disease, we assure you the stock here on the market. Okay. And some of you knows better. Even some NGOs knows better. Thank you.
Thank you very much for the questions. I want to be able to take all the questions. Let's hear from the panelists. After, if we have enough time, maybe we can take more questions, but time is not on our side. I won't repeat the question. I saw them writing down the questions. We start with Dr. Evariste. After we have Dr. Julius and Valentine answering the question which were addressed to you.
Okay, thank you very much for the good questions that have been raised. Let me start with the first one of existence of the protocols. I should say comfortably that the protocols and guidelines are available. When we started the program of NCDs, we had to do first three things. One is to develop policy, number two, strategic plan, number three, to develop the guidelines and protocols. Just because we don't have specialized doctors in the periphery, so we use the few doctors, the cardiologists, the endocrinologists that we have in Kigali. They help us to develop, in collaboration with, of course, stakeholders, namely WHO, partners in health and others. We developed guidelines and protocols. They were put at the district hospital first, and then as an intermediary level for transfer of complicated cases, but also to receive the cases from health centers. And after getting that they had, after like some time, patients were many, and also we developed another simplified protocol for nurses at health centers. And that's why in my graph you saw that so the patients are increasing at the level of health centers, and they are being managed by nurses. And a study that has been conducted by doctors from Sashika, they have found that district hospitals currently are treating hypertension better than doctors in Sashika. It's themselves who conducted that assessment. So they are due to publish that paper, so we need to continue and then see if we can advance. Number two, maybe I can go quickly because I think it concerns the program about that and industry and the policy. Of course, I told you we developed policy for NCDs, prevention and control, but this time we need to go with specific risk factors. At least we have gone far with tobacco. We have a law governing on control and use of tobacco in the country. We have taken a step. Number two, physical activity. You know, so many stakeholders have done that. Then number three, we are developing policy on alcohol, but we have not left nutrition aside. We have guidelines for nutrition, but besides that, since morning, the presenters, the topic was multisectoral intervention. And that's why we can't act without Minister of Agriculture. Of course, I can't go further to think about the pesticides. Of course, that's why we need to do research and withdraw. I don't think that the Minister of Agriculture can introduce the chemicals that can affect our population. And if at all they were there, it's our duty to conduct research and then we advise because we are in charge of that. So I think that's that. Concerning the supermarket selling things, of course, one of the tools of public health is public awareness. So it's not because the fruits and vegetables are not accessible, it's just because we are not sensitized to use those kind of foods. For example, I normally give an example. Daily wage of a worker, casual worker, has gone as 3,000, as far as 3,000. Like people go to construct houses. And then that's the Mufundi is like around 5,000-6,000. But guess what? After work, where do they go? To the supermarket to buy fruits or to the bar to buy alcohol? So it's a matter of choice. We need to teach them. So we need to teach them, and then they get sensitized to know that they should use the health foods, because we're not going to confront with the industry that, oh, please stop producing chips. No. Remember how many in our country countries around that have malnutrition, compare malnutrition due to deficiency and malnutrition due to excess. So we need to teach. That's where we go and we tell those people who have less, please take those foods. And then we go for you guys who have a lot, then reduce. It's a matter of
Hello? Yeah, I think much is said by my friend, but one question asked about data from my presentation. There is already data, HMIS data and electronic medical records, which is used in HIV management. But what I mentioned as a gap was around the, if someone has diabetes, and you want to know if they have HIV, is the one that you cannot get in the medical records, which I think still I emphasize probably the people who developed the guidelines were conscious of putting someone because of stigma that maybe confidentiality matters. But I recommend that since we use TrackNet numbers, we need to correct this data if we have to make uninformed decisions. And of course, research and surveys are very core and important for the purposes of making decisions, but it is really core. Maybe I tackle the case of medical supply by someone who asked about the stockout assuring availability. Yes, there is you may find that there are availability at the market, but the issue of financing at the health facility level may not be enough unless it passes through the normal channels of the district hospital to be found in the district pharmacy, so that the health center is able to procure from the system. Sometimes there are stock out, not always, but that one has to be taken into consideration and ensure quantifications are done on time, are trained on doing them, so that we keep our system functional throughout. But still, from the supplier point of view or the distributors, you also need to be considerate to supply enough so that we don't have stock out at the level of the country, so that when people have money, are able to get the medications. Thank God for the antiretroviral, at least over so many years, we have had no issues related to stock out of antiretroviral, but still NCDs, there is a need. Someone also asked about issue related to multi-drug pill take or the pill burden of both antiretroviral drugs and also the NCDs, mentioning an example of hypertension. Yes, there are some interactions on some medications, but for example, people on TB may have issues of related with medications on diabetes, and but all this mostly should be solved by continuous mentorship and training from the mentors at the district level, and also transferring the skills that are needed, so that. But another mitigating factor that is around is that if people are to have these multiple drugs, maybe if they have co-infections and they have to take more than usual drugs, the recommendation or the guidance is that you involve a highly specialized doctor to give the guidance on the medication use. So all these ones are taken into consideration, but as said, also coming to what Avery said, guidelines are developed, but also are adapted over time. And I think it is done and it has to keep on being done so that we ensure continuity of supply, we give continuity of an effective treatment, both HIV and NCDs in general. Thank you.
Thank you very much. Before I tackle to the questions of research, I want to talk a little bit about a question of the protocol use. I can say that, as Dr. Ntaganda said, we developed the protocols, but about the use, I can focus that as we are here, like especially the medical student, I think sometimes you are aware about what is available, but maybe at the root site, maybe they are not aware where you can find that they are using the protocol from outside. I can emphasize that as you see that, you can try to communicate. Regular communication and staying in touch can help us to improve our health system. Thank you for the question about the population we use in our study. We have like 3 groups of participants. We have a group of HIV positive who were on antiretroviral treatment for a long time. We have also another group of HIV negative, and also we recruited a group of newly diagnosed HIV positive. For newly diagnosed HIV positive, we are still recruiting. We enroll them as we find them in the health selected site. We were also supposed to have another group about the people who are HIV positive who are not taking the antiretroviral therapy, but as you are aware, we are in the system where we treat all HIV positive. This was not possible, and also we are glad that we are recruiting those who are newly diagnosed. This will bring a new things where we know exactly the baseline characteristic of the participant before they start to take antiretroviral therapy. Because for the others, we can get confused if they had like hypertension before they start to take treatment, to know exactly if hypertension or another NCDs they will have will be linked with HIV or antiretroviral therapy they will be taking. The question about the other risk factors, here I presented BMI, but we assessed a lot of risk factors, as you know, like smoking, eating habit, or physical activities. But this was a short screenshot about what we found. We present in the other conference, and you are welcome to be interested in our study. Maybe comments are welcome. And for the other things about the genetic factors, this is the part of what we will do in the next phase, not in the current phase. Thank you very much.
Bringing to a close to our panel discussion, I would like to apologize because I won't take another round of questions. And online, I won't be able to take questions, but I would like to ask the organizing team to type answers to the online people following online. So I would like you to give a round of applause to the panelists as they are joining back their seats. Thank you very much.
Thank you so much. Thank you so much. Of course, this is an exciting topic. We can go on and on, but the good thing, we still have our speakers here. We'll have them tomorrow. So if you have a question, please feel free to join them and then address the question you have. Moving forward, allow me to introduce the next moderator for our next session. Our next moderator is Karin Akope Aisu. I hope I pronounce it well. Thank you. She's going to lead us through a panel discussion about technology trends in NCD management. You're welcome.
Good afternoon, ladies and gentlemen. Thank you for giving me this opportunity. I'd like to recognize especially the president of NCD Alliance East Africa. Thank you for giving me this opportunity. Now, ladies and gentlemen, we're talking about NCDs. Could you please rise up on your feet for 1 minute? Could you please rise up on your feet for 1 minute? And you're going to say what I say and do what I do. I'd like you to say, I know NCDs. I know NCDs. They are dangerous. They are dangerous. Go tell someone. Do what I do and say what I say. Say, I know NCDs. They are dangerous. Go tell someone. Lift your leg. I know NCDs. They are dangerous. Go tell someone. Come to your hip. I know NCDs. They are dangerous. Go tell someone. That's what we are supposed to do. You may be seated, please. You know, when we're talking about NCDs, do something with your hands. Look up. It will save you the stress. Look up and down so that you don't get a migraine. Thank you very much. Ladies and gentlemen, this afternoon I'm so privileged to be one of the moderators talking about technology trends in NCD management. Somebody asked about this while we're discussing in the morning, and my heart was leaping because this is something that is very critical today. And we have very key panelists that are going to be discussing this today. One of them is actually the former director, General Clinical and Public Health Services Rwanda. He's also the one who undertook the role in establishment of Ministry of Health Public Health Operation Centers, currently serving as a command center for COVID-19 Joint Task Force. I'm not talking about a simple person. He's also participated in the inception of COVID-19 home-based care program in collaboration with the National Task Force. My people in Rwanda, this gentleman is the managing director, the chief operations officer, the chief medical officer of EDPU. Join with me, ladies and gentlemen, to welcome Mr. Dr. Zuberu Muvunyi, please. You can do that better. You're helping yourself. A round of applause as he still he sits. He's not a simple man. Thank you, sir. You may be seated. Now I know everybody's alert. Thank you very much, sir. You're welcome. People in Rwanda today, NCD Alliance has made something remarkable we can talk about. This is the first time NCD Alliance is organizing this. They have done it so well. Give them a round of applause again, please. Technology trends in NCD management is very critical. And with me, ladies and gentlemen, in my panel, there are very strong men and one superwoman right here. And they'll be discussing on it. Join with me to welcome someone who is a pharmacist by profession. He's also a member of the Pharmaceutical Society of Ghana. He's had experience working in Nigeria. He's had experience working in Cameroon. And he's brought the same experience to Rwanda. Ladies and gentlemen, welcome with me someone who is the head health systems integration. He's none other than Mr. Seneke Samuel from Zipline, please. A round of applause for him. Wow. After that introduction, you must do your best. Allow me to sit next to the gentleman. Please give me a round of applause. Celebrate yourselves. Would you like some water? Are you okay? Are you ready for the session today? So, I'd like to start with you, the MD. All those titles, I like that. When I grow up, I surely want to be like you. Just give me a few years. I'd like to ask you a simple question. What is it that EDPU is doing right now? For someone who doesn't know what you're doing, how are you doing it? And what do you do when you do it? I've asked you so many things, but you understand, maybe I'm very confused looking at your bio. You can understand everything. Please explain to us. Thank you.
Thank you very much, Caroline. First, I would like to thank the organizers of this conference and the opportunity given to me, to us, to EDPU Africa, to be part of this long-awaited event. As you said, everybody knows NCD. But question is, the healthcare professionals, the people themselves, do we know how to prevent? What are we doing to prevent NCDs? Is it
You're allowed, please.
Allowed to remove the mask? So that is a question. And that is a question the EDPU Africa is trying to respond to. And EDPU stands for Early Detection and Prevention. U is unit. It is in a unit that can be static, fixed, or mobile. So how do we do that? What do we do exactly? Actually, we screen people and establish a risk stratification for NCDs and provide, according to the results, to the data, to the information received from the system, we provide guidelines or recommendation just to keep healthy people in good health. And the other thing I want to highlight is that we do, like, let's say, triage for specialists or specialized diagnosis entities. What we observe today is that someone will go for medical check, either because he has some concern, health issues, or not. And they have to wait. And there is a problem, a long queue. Waiting time is so huge. And EDPU Africa is actually narrowing that, shortening the queue and allow the patient the people to get the right diagnosis at the right time and further maybe transferred to the right specialist and get the right treatment. Two things I want also to highlight is that we are mainly focusing on digital health because our processes can be summarized in two or three steps. First is an intelligence questionnaire, which is digital. The questionnaire will trigger some additional specific medical, clinical measurements. For example, ECG, for example, blood pressure, of course. For example, some rapid tests for colorectal cancer, for example, spirometry for COPD, and this both combined all connect to our system, the EDPU system, will determine the risk for a particular individual, and that risk will be discussed with the doctor, a GP. If necessary, if the person presents really major health concern, the person will be referred to a right specialist or for additional investigation and further management. So, if I still have some 1 or 2 minutes, we are not, myself or our team, we are not doing that just for doing that. It is a passion. Some time back, some few months ago, when I was working with the Ministry of Health, really I had passion for, many questions, and asking myself, how can we improve the prevention and further the management of NCDs? And to me, the prevention was the most important, and again, make the whole thing digital, accessible to everybody, and actually engaging the patient or the people themselves to do, let's say, like own screening, at least with the questionnaire. So maybe I'll elaborate later with the interaction with the participants, the great people around it, in this conference. Thank you very much.
Thank you very much. Mr. Samuel, it's an honor to sit next to you. Tell me a little more about Zipline. I've heard about drones, and wow, Rwanda is doing very well. A round of applause, please, to Rwanda. You're doing very well, and East Africa should copy from Rwanda. A round of applause, you can make it better. Mr. Samuel, could you tell us what is Zipline, and what do you exactly do? From the name, it seems so confusing to me, but help the people to understand what exactly you do. Thank you.
All right. Thank you very much for having me, and then actually letting me be part of this panel. Fortunately, I'm seated by one of the founding fathers of Zipline, so I'm very honored. So the very short definition of Zipline is a drone company. Everybody knows that in Rwanda. So, but I would say Zipline is a transformational healthcare logistics company that specializes in delivering medical commodities, blood, samples, that's biohazards, anything that has to do with universal healthcare, and also has to do with patient needs at the hospital. Zipline, just a brief history, was started in Rwanda, and then that was in 2016. This came about with the vision of the president to transform the logistics and then the supply chain in the health sector. After implementation, I think a whole lot of other countries have been coming on. We have a lot of distribution centers in the US. We have about 8 distribution centers in Ghana. We are also in Nigeria now, moving to Ivory Coast. So it's becoming really big, and then that is because of practically what we do, and then the emergency response that we have to be able to reach health facilities within the shortest possible time, under circumstances where traditional means of delivery would have taken around 4 or 5 hours. Zipline does it within 45 minutes. So that is the very special thing about Zipline. But then basically we are just a healthcare logistics transformation company.
Ladies and gentlemen, what would take 1 hour takes 45 minutes. Zipline drops blood, drops drugs in 45 minutes. And he says, one thing that piqued my attention, it was launched by the president, His Excellency. Could you please give a round of applause to the president of Rwanda, Kigali, and notify him that NCD Alliance Kigali is so proud to have him. I would like to ask a question. Doctor, we are still in a time when technology is a challenge. People are struggling. The government probably, not the government, the community is slow to adopting it. And probably some challenges also financially in the Ministry of Health to adopt it. And maybe people may not be able to welcome it. How are you doing it as EDPU? And how do you cope with the communities and the environment that you work with? Thank you.
Thank you very much for this very interesting question. Actually, digitization is not that much a challenge here in Rwanda, because we have all conditions really to do whatever we do in the healthcare systems. We can do it digitally. Actually, Rwanda is moving the Rwanda healthcare system, and there are people from the Ministry of Health to confirm, is really moving from manual healthcare management to digital healthcare provision. And for us, maybe we come at the right time. First of all, Rwanda, the broadband, I mean the fiber is almost everywhere. And the 4G is also everywhere. So now the penetration of smartphone, for example, is also increasing day by day. But of course, many people are still using not smartphones. So that is something people are working on, and we are really also distributing smartphone through different channels, through different level of our society and community. So you have noticed that EDPU Africa, it is EDP Africa. So we may not have problems here in Rwanda, but our next step, we are aiming other African countries, and where probably will face that kind of problem. But adopting the digital way of doing business in the healthcare industry in Rwanda, really we have, let's say, favorable or friendly conditions for healthcare professionals, but also for patients, for people. I don't like to qualify people as patient. They are clients, they are customers, but they are not necessarily patient, especially for EDP Africa, where we want people to stay healthy as long as possible, and mainly prevent the major NCDs leading to morbidity and mortality. These are diabetes, for example, cardiovascular disease, CPOD, and cancers, of course. So, in brief, we have all conditions are set digitally saying in this country really to move forward. And again, DPU Africa and other like Zipline and Babil, who is not present here, we are actually making a proof that digitalization of healthcare system is the right way to go. And we're already doing it, but we still have a long way to go, but we are somewhere, and results have shown that we better deliver healthcare when we are digitalizing our health system. For sure, integration is somewhat some of the challenges, but also we are also doing some progress on that. So, in summary, it is an opportunity rather than a challenge. I mean, the digital health here in Rwanda.
Ladies and gentlemen watching us live from all parts of the world, you have heard what the MD EDP Africa is saying, that instead of looking at it as a challenge, it is an opportunity, and they're embracing it here in Rwanda. We are talking live from Rwanda, Kigali, and please comment on hashtag on Facebook and every channel that NCD Alliance East Africa, in partnership with many organizations, are talking about technology as a very important aspect in healthcare provision. And I like what Tuhi has said, that it's going to move out to Africa. It goes back to what we're saying, that collaboration will help to free NCDs in East Africa and in the world. I'd like to go to you, Mr. Samuel. If I were to ask you a question, which I know you're very comfortable to answer, please, if you're not, whisper to me, but not through the audience. What is the impact of Zipline on the ground? Before we think of taking it to the neighboring countries, and you're very welcome to come to all over East Africa, but what is your impact on the ground? In brief, thank you.
Okay, it's good you said briefly, so I'll use the whole day here. So our impact, I would like to categorize it into 3 different levels. One is I'm looking at the national impact. 2 is the impact at the healthcare center, and then the health professional, and then another impact on the patient or client, as our founding fathers say we should use. So looking at on the national level, since we are working with suppliers, we are working with the RBC, we are working with BTD, we are working with RMS, we are working with other private entities as well. There are these instances where there are scarce commodities. Let's say we have limited insulin that needs to go to patients that have diabetes, and then they are limited insulin. From Zipline's hub, we are able to access 25 districts. that means we just short of 5 districts, and these are just because of regulatory implications. But then we can access 25 districts. Now the benefit of Zipline is if the suppliers had to drive to these 25 districts to do this distribution, you can't forecast the consumption of the scarce product. But with Zipline, since we do on-time delivery, when the patient comes and needs insulin, they just order the insulin from Zipline, and then we deliver the insulin to the patient that needs it. This is the biggest challenge that most of the suppliers would have, because you can't tell, or you wouldn't be waiting for an emergency order to come, then you take a vehicle driving to the facility to go deliver the product. But centralizing scarce resources as Zipline means that these patients have the product on real time and real demand. The other benefit we have on the national level is looking at expiries. With the amount of quantities that we deliver, the patients are comfortable to request for near to expire products in their comfortable quantities. Usually the challenge is if there are near to expire products, and then the patient or their facilities will have to order for the product, and it has to be delivered by truck, and this product is in a limited quantity or small, the unit economics actually doesn't match. But when it comes to Zipline, the facility knows that, okay, with Zipline, I can order for just 1 week consumption. So they are comfortable, ordering for near to expire product that they can just consume in a week, and then they just order for the product as and when they need it. We are also looking at reduction in referrals, where we have most of the ex-urban areas, due to lack of medicines, have to travel all the way to urban facilities, and then they have to get choked at the urban health facilities, thereby causing so much pressure on the facilities and all that. We are looking at these distributions actually makes these patients very comfortable receiving treatment at their homes or at their resident district, thereby lessening the burden on the healthcare facilities at the urban areas, where they have more concentration toward much more critical cases, especially the case of COVID, where every hand is on deck. This is very crucial. When it comes to the health facility, now I already mentioned the benefits are kind of intertwined. So the health facilities can comfortably order for products in real time when the patient needs it. If the product is even near to expire in a month or 2, and then there's an active case, the health facility is able to order for the product. It also eliminates the risk of health personnel traveling to the district pharmacies to go pick certain emergency medications, come back, come treat patients. Now all the personnel in the health facilities are concentrated and fixated on the patient. Just with a phone call or a text message to Zipline, they receive the necessary medicines they need to take care of the patient, and then they wouldn't have to travel around, right? So these are some of the benefits. We're also looking at stockouts. Zipline works in reducing stockouts. So there are these instances where health facilities run out of stock of products, but we practically know that there are certain products that forecasting is so difficult because the demand is very sporadic. And in such instances, Zipline is the best bet, because since forecast is difficult, they know that as and when they need a product, they can just call Zipline and then we deliver the product for them. You understand? So we try to eliminate actually stockouts from the health facility, and thereby entrusting the patient that whenever they go to the facility, the facility doesn't have the medicine, they know that the facility can make an order to Zipline, and then they don't deliver it. But when it comes to the patient, so now the patient doesn't have to travel long distances in looking for quality healthcare or universal healthcare. They know that there is equity in distributions of essential medicines wherever they are. The same medicines that is accessed in the urban areas, those in the ex-urban areas can access the same medicines. They do not have to travel to the urban areas and get confused with our high-risk buildings. They just can receive the same quality of care in their resident districts and their resident homes. So this actually has a lot of other implications, like economic implications, where if you have to travel, you have to send a patient relative to go take care of the patient. But if it is in your comfort home, you don't have to do that. You don't have to look for accommodation for yourself and an extra additional person. You have the concentration of working in your farms. So there are a lot of benefits. If I don't stop here, I think I might have to take the whole day.
And those watching us live, I think you can see on my background, the drones are going all over. I'm actually getting tempted. I thought that I'm going to take the next drugs to the next center. So if you can hear me and you're inside and you're watching me, could you please lift up your hand and wave to the panelists here? Because they need to know that you're alert. Thank you very much. I pick two things. That when someone is sick, the medical personnel doesn't have to run to a pharmacy. They have to give full attention to the patient. And all they need to do is, hello, zipline, I need insulin here. I didn't know that Rwanda is ahead like this. Another round of applause for Rwanda, please, my people. And my president is right here. Please, next month, relocate me to Rwanda. That's a very good one. And I pick another thing that you can be in your garden, not well, and all you can do is just call that, I need help here. And what is also interesting on the other note, if you're up country, you also feel you enjoy the place seeing a drone coming around. For some of us who've grown up in places where you don't have to see an aeroplane, that's also interesting. A round of applause to my panelists, please. I'd like to ask EDP Africa, EDPU Africa. One of the things that I see is helping this. I'm very happy that Samuel said you were the founders of what is happening right now. Could you please tell me a little more about collaboration? Which people are you working with so that the people around this place and those watching can go knocking doors, because we have seen a successful product from collaboration. Who are you collaborating with? And that could be, is it only in Rwanda? And what could be the future plans that you have to reach other places in Africa and the world? Thank you.
Thank you very much. First, there is an international partnership. Actually, EDP Africa is partnering closely with a Belgian-based, it is also called actually EDPU Technologies. It is based, and is the one owning the IP, the intellectual property, because the solution has been developed by EDPU Technologies based in Belgium. The same solution is being implemented for many years now in the UAE, Emirates, Dubai, and it is really helping people to stay healthy, and detection or screening of NCDs is done early so that prevention is also possible. Now, at the national level, of course, we can do this kind, implement or start this kind of, not revolutionary, but innovative way of providing healthcare to NCD likely affected people without the help and the support of the Ministry of Health and the support of the RBC. And for that, we have even been privileged to work with the division led by the head of the division for NCD, Dr. Francois Winyindi. We are partnering closely, we are guided, we are supported by the Ministry of Health and the RBC. And because we are starting now the phase one, the pilot phase, we are going also to partner with the hospitals and the health centers. And health centers, when you say health centers, it is already community. Now you said collaboration, integration. Of course, our solution is digital, and we integrate what we have with the hospital, health facilities, electronic or medical records. At the same time, we have opening a private clinic mainly targeting corporate institutions like banks, like other private institutions, and they will be able to go for screening and go through the ADP processes at our clinic located in town. And that is a collaboration with the community and other people. And the other thing is collaboration with the other health institutions. For example, pharmacies. You know, NCD affected people, they consume a lot of medicine. sometimes 3 of different type to 5. And EDP Africa is also helping for therapy compliance. And other institutions, so the list is really long. Now, coming to the question of the future plan. After the phase 1, of course, we are going to go to the phase 2, which is the full deployment, the rollout. And at the same time, we are working to export the solution. After the proof of concept, that is the rule, the rule. So we are going now to also to export and approach other countries. And some of our customers are implemented in the whole East African community. For example, banks. So now they are already asking, when are you going to come to our country? So it's something we are working on, of course, but first we have to achieve the proof of concept, achieve the pilot phase, and with the permission, a further recommendation from the Ministry of Health in charge, then we can move forward. Here, the national. I told the same thing with my colleague here, Zipline. They started here, proof of concept, and now they are in Ghana and the other countries. Thank you very much for a very interesting question.
You're welcome. Those watching us and those inside, one thing to pick is that the concept has already been proved. And so whatever country you're watching us live from, don't worry. EDP Africa and Zipline will knock at your door shortly. But remember, key is collaboration. I have a question for you, Zipline, but I'm tempted to say, if there's someone who has a question, this could be a moment. I'll ask you something in relation to data, but that is something you need to prove to us. I know that someone is managing the slides. Could they just put the slide on, particularly concerning data? But before you come in, if there be someone here, if you have a question that you'd like to ask the two gentlemen with a very active, very instrumental, and those watching us online, this could be the moment. You could type in your question. It can be on Twitter, it can be on Facebook, it can be on Zoom, and we can ask the expertise that are here. Remember, technology is very key for us to deliver healthcare timely. So Zipline, my last question to you right now is, do you actually have data? I know it could be a question not to ask, but it's good for people here to know that what you're talking about, you're aware about it. And how has that data helped you? You're talking about, EDP has talked about future plans. What are you planning to do with the data that you now have? And if you have a question, please jot it down. This is your moment. Before the gentlemen walk out, do not go out without answering something that you need to ask. So please tell us a little more about data, and do you actually have the data? Or this is something, I know that you've moved from Ghana, Nigeria, but started from Rwanda, and this is something that is interesting for us to hear. Thank you.
All right, thank you very much for the question. So I think now everybody agrees that whichever institution or entity you work in, data is very paramount. I don't know if you have the slides, if you got the slides, so you can just put on the slides and then just scroll first to where the graph starts. I just like to do some remarks in that respect. But then, with Zipline, when it comes to data, actually with the suppliers that we work with, BTD, RMS in particular, we have live feed data that we give them. So when a product drops at the facility, they see we have a shared interface where they see that, yeah, they have sent this product to facility A, they've sent it to facility B, so there is that live feed of data that is being given to them. However, we've also been working with PIH in delivering some of the NCD medications, like the cancer medications during the COVID. These are some of the data that we also would like to give in that respect. But then we can just scroll to where the graph starts. Let's skip all this. Okay. So this is our partnership with PIH, where we deliver cancer medicines. But then let's continue, move forward. There are graphs. Okay. So this is a demand graph in Rwanda right now. And this data actually ends in October. So when you look, among 100 plus 150 SKUs that we actually deliver, we've done more than 100,000 blood units delivery. we've done around 91,000 medical product deliveries. And these all deliveries are done in 25 districts that Zipline serves, and then in more than 350 health facilities that Zipline serves. My interesting part, my fun fact is where the 2021 actually starts, where the pandemic struck, and then a lot of restrictions were placed on movement, and then quarantine was imposed. The major question was how patients were going to get their medications. So if you juxtapose deliveries done in 2021 versus deliveries done prior to 2021, you will see that deliveries done in 2021 are about 3 times the cumulative deliveries that have been done ever since the line started. This is the kind of deliveries we have done in support of people with NCDs. Let's go to the next slide to be much more specific on the data. So NCDC medications that have been distributed. So you will see the first one is hydrochlorothiazide, which is an antihypertensive medication. So these are some of the medicines that we've actually delivered. And then if you look at the SKUs, about 13,000 of these medicines have already been delivered to 223 health facilities, 27 hospitals, and then through the 25 RMS districts that we actually currently operate, which means that 100% accessibility and 100% equity of access to essential medicines, even in the middle of COVID-19. Let's go to the next phase. Just want to, okay. And then this is the quantity of products that have actually been delivered per SKU. So you will see our top two, okay, so our top two, captopril and nifedipine, which are antihypertensives. The next one is salbutamol for asthma. Then we have insulin in there. So these are the public partnership data that we actually have. The private partnership data, I don't have the permission to actually share that, but that has to do with our partnership with PIH, where we deliver cancer medications to their patients who couldn't travel to Butaro during the lockdown and then restrictions to actually take their medications. And then the last slide would see vividly what actually practically happens. So this will tell us about the deliveries and then the safety measures, 0 injuries, the reduction in wastage, about 98%, more than 98% reduction in wastage. Millions of lives we've contributed in saving millions of lives. So this is the practical data that I want to give visibility to you on. Thank you.
Thank you very much. A round of applause. Being in front here is not easy, if you can understand, but you're doing so well. Is there anybody who has a question that you'd like to ask? This is the moment to clarify. Yes, please.
Yes, thank you very much. I would like also to respond to the same question, but in a different direction.
Please
if
go
I may
ahead.
say so.
Please go ahead.
Remember, EDPU Africa is about artificial intelligence tool that will fetch from the database. Actually, whatever we do is data-driven. So the AI will fetch from the database. For example, the questionnaire answers you provide to the system. For example, the clinical measurement you send to the system. And the AI will analyze, process that information, that data, and provide a risk stratification for each individual. Now, the data after that, the data is in the first place for the individual. Before we even start to do anything with the client, there is a consent form. So do you agree that your data being used for, so in the first place, the data is for the individual, for the client. Second, of course, for EDPU Africa, but most important for the Ministry of Health. This data will be even used to develop our register for NCD, for example, cancer registry, for example, diabetes registry, and will enrich the data, the current data we have. So all is about data, all is about artificial intelligence, because you are and I will show that in the next slide, if you give me time. Whatever we do is data-driven, is artificial intelligence to save time, to provide individualized, personalized health care to individuals. Thank you.
Thank you very much. This is a moment for questions. Ladies and gentlemen, if you do have a question, with permission granted to me, I'd like to ask for 4 questions, please. You know, when people don't ask questions, it shows they're very satisfied. Okay. I have seen hands raised up. Could I please start with the president? At East African level, we call him the president. At Rwanda, we call him the chair. So please, President, take the privilege to be the first to ask the question. He's allowed you to. Go ahead, sir.
It's a privilege, actually, to be sitting close to the president. So, I have just a question, and it's, I think it concerns both of you, the presenters. I'm seeing that EDP Africa is trying to promote digital technologies in NCDs prevention and the control. The same Zipline is trying to make the logistics much easier, much seamless. And so I'm really thinking about, we've been talking about this morning about e-prescriptions. So as the number of patients is increasing, we don't need everybody to come at their facility. I'm seeing opportunities for EDP Africa to do those e-prescriptions, especially for those patients already enrolled in the program, and then they can go to different pharmacies and get drugs. But can you do, and the same, I'm also asking myself, how, for Zipline, did you think about maybe home deliveries? I know maybe depending on where people live. So I'm just seeing it as a collaboration that can be between EDP Africa and Zipline. EDP Africa do e-prescription, and then Zipline can be able to deliver at home. So, this is maybe something that can be explored. I know that depending on how people live, maybe not going to each and every home might be really challenging, but why don't we even go beyond the health center level and probably be able to deliver drugs maybe at the village level, you know? These are things that really can help our patients, because especially for our patients that are living in the countryside where they don't have access to these private pharmacies where they can even buy drugs. And the second one to Zipline, it's really interesting, and we are also thankful that you helped us to deliver, especially breast cancer medicines during the lockdowns. So it was really very, very helpful. I'm wondering, what about technology transfer? How can we make sure that really now we have really now young Rwandan is able now to be able to take over and really run the business, and even so, because as Rwanda has been one of, probably we're the first country that helped, to prove this concept of maybe delivering medicines using Zipline. So, and you know that there is of course a cost behind it. There is a cost behind that one, and for the sustainability, and they also be able to continue doing that. So I was wondering maybe how can we, how can that technology be transferred to, to local people, run it, and even just with very, very reduced costs. We know that now it's somewhat becoming expensive, but how can you reduce the cost and then have local people running the business? Thank you.
Thank you. Over to the president now. We'll take all the questions and then
thank you
we'll
very
respond.
much. Really, really interesting. Dr. Muvunyi, I'm very happy to hear more about EDPU Africa, and the Rwanda NCD Alliance as civil society is very much interested in going down to the community. And we have been doing a lot of screening during car-free days, during different campaigns. And one of our challenges is to manage the data. So I hear that you are data-driven. Could you imagine a collaboration with you in terms of screening and bringing together data from the different sources? I imagine we have already created platforms. Instead of us reinventing the wheel, could you imagine a partnership so that we work together, particularly those registries we are also very much interested. We know cancer has started. We have tried to put together rheumatic heart disease patients register, which is not yet, but then it is beyond screening. But one of the problems is that in any platforms or electronic medical record, there is a need for harmonization. Not everyone having his own medical file or system, so that we can one day have tablets with at every health post and at every even community health worker, so that people could enter data easily in an easy platform, web-based, which every stakeholder can use or benefit from. Is it a dream?
Thank you very much. I saw a hand right there. And I don't know if there's any question on Zoom. We could take one from Zoom and gender balance, one from the lady. Thank you.
All right, thank you so much. My name is Ange Umutoni. I'm a pharmacy student. My question is going right to the zipline. First of all, I would like also to congratulate everyone for the work that is being done. And thank you, moderator, for a very insightful moderation. It's very powerful. So my question is, I saw that you deal with early warning. For the people who are placing the order, they need to go through the early warning. So how do you handle the emergence cases? Is there any way, like, for example, if the health center is ordering maybe an hour before the need of the product, is there any way that you use, or you only just use the early warning, you do not take the emergencies? So I just wanted to understand about that point. Thank you.
One last question, if there is one. Yes, would like to pick the gentleman there, and then we'll respond. Thank you.
Thank you, moderator. My name is Nimbawaz. I would like to ask a question for both the speakers, and it's related as we're talking about the multisectoral collaboration for NCDs and UHC. I would like to ask at which extent the integration of technology and delivering the NCDs services has reduced the cost of the services, because one of the challenges we still have about NCDs is the access on the drugs or the materials required for NCD treatment, which is still high in terms of cost. So using the example of Zipline, do you think there is a way having the availability of the drugs and integration of the technology to deliver them has helped the people to access more on the services and the drugs than it was used to be before, so as considering that it is also contributing to the UHC? Thank you.
Thank you very much. I would like to start with Zipline for now, then we'll go to Dr.
Sorry,
Mufoni.
moderator, I have the mic.
Oh, go ahead.
And I am older, so...
Go ahead.
And I have got few questions.
Go ahead.
Most questions are for you. Well, e-prescription. So, EDP Africa, we are not as such in e-prescription, but remember the risk classification profiles are directly sent to the client email, if the client has one, or a message, a simple message, an SMS or something, but preferably an email. So of course, it's not everybody has an email, but we also look, trying to also to fix that issue. That is one. Now, and moderator, you talked about, one of your questions was partnerships. Actually, we need to partner with EDP Africa, need to partner with this blind, because one of our module is therapy compliance, and we are helping people again to deliver. And the COVID-19 pandemic was a lesson for everybody. So we have seen home deliveries for everything, food, clothes, coffee, whatever, but many people suffered for stock out of essential medicine. Can you imagine someone on insulin, for example, Professor Muchumbisi? So if you don't have your dose, then you are dead. And this happened really during the lockdown. So we need to partner with the Zipline, because we are also working on therapy compliance. And you have actually a specific program called the Improved Medication Intake Program. And we have already discussed with the pharmacy chains, but we also need to include, if you allow, of course, Zipline. Because as I see their concept of operation, it is very difficult for them to deliver to each household, even to each. But if we partner with them, we can facilitate and again work with the pharmacy chain. So that is that's something I wanted to highlight. Now, thank you, Professor Muchumbisi. Actually, I have a feeling that you got access to our concept notes. Because something I forgot to mention, I didn't get time to develop, is our mobile solution as well. We are working in the hospitals and the health centers. We have our own private clinic, prevention clinic. That will be like the first time in Rwanda. We are used to clinics, polyclinic, hospitals and so on, but prevention clinic is something that doesn't not exist really in Rwanda. So we'll be the first one maybe to operate this kind of clinic. But we want also to reach everyone, wherever you are, in the remote. And remember elderly people, they are in the village somewhere. And there are those who really want health care for NCDs. So we want to reach them out using mobile preventive clinic also. And we go there, we give them the questionnaire, we do the screening, the clinical measurement, and we tell them this is your status, this is your profile. So we are going to do that. And again, the car-free day, what we call car-free day, I don't know if everybody in the room is aware of that, but after exercising, everyone goes for medical check. And the thing is, we are still doing it manually. Now, with EDP Africa system, we just deploy a vehicle, a truck, a tent, and when we screen everyone who wants to be screened. And since the data is digital, we just send to the central system of RBC, of EDP Africa and RBC. So we can retrieve the data, we can continue to enrich our database and the patient registry. So that is someone we are really want to do very, very, very soon. And again, we are here not to just to present EDP Africa. We are not here to market EDP Africa. We are here because we had this conference of NCD Alliance. And that was a great opportunity to start partnership. Partnership with NCD Alliance and EDP Africa start now, from now. And we expect to have really strong ties, a strong collaboration and partnership in the near future. Thank you very much. And again, there was that last question about integration. I don't know, myself, really, my passion was e-health. In the beginning, it was called e-health, and now it is called the digital health. We have a full-fledged division in the Ministry of Health for now. So now what the ministry is trying to do, what Arab is trying to do, and of course, as partners we are trying to do, is to integrate our solutions. We know we are very much aware when we went to visit hospitals here in Kigali and elsewhere, we went to understand what is open MRS is able to do now, right now. And I'm happy that in all hospitals, and private and public, they are all using one or another electronic health records. And others are using Open Clinic, for example. So we make sure that EDP Africa system is integrating with other MOH RBC system. That is the only way to go. We are not going behind. Go back to the working in silos or working in manual. So it is digital, and you are integrating, and you are sharing data and information on patients. Thank you very much. And if possible, as soon as possible, you remember what they say, one patient, one file. So you don't need to move from, I don't know where you are from, let's say from Karongi to Goma, carrying your big file. So they just send your file digitally, and all is done. Thank you very much, and I let my brother now give his answers also.
Thank you. Please wrap it up in a minute or two. Thank you.
Okay, so I just do it first. So I was just in this conference, and then Dr. Sabin told us that why we were defeated by COVID was because COVID acted as a team, but we acted as individuals, and that's why we were defeated. So I would take the president's remark as a challenge to us to collaborate and work, and not an ask. It's a challenge he's throwing to us to work together. With regards to home delivery, actually, yes, it looks like you are with us in the spirit. So our next phase of work is home delivery, and we are coming out with a Platform 2 drone that can do a very accurate delivery at the home of people using GPS systems. So that is coming up. With the knowledge transfer, so currently we actually do internship programs for a lot of the tech NACs that are in Rwanda. Anybody that has the NAC for tech, we do internship for them. They can come to our distribution centers, or they can reach out to me, and then I can give them the arrangement. They go for internship at the distribution centers. So that is in place. Also, we are building an auto-modern facility where we have an academy where people from the US, Ghana, every other place comes here for training and all that. So that is also in place. How we handle emergency orders, like you asked, that is very important because if somebody is suffering from postpartum hemorrhage and then somebody has a headache and then there's no paracetamol, there's no blood, what do we do? So our system has an AI incorporated into it where it prioritizes the emergency deliveries. So if an emergency delivery comes and then the rest of the orders are not emergency, the emergency delivery will take paramount, and then it will be prominent on the system. If we do not pack the emergency product, you are not allowed to pack any other product. And if the emergency drone doesn't fly, no other drone can fly. So that is how the system works. So emergency products are usually prioritized. So that settles it. And then the impact, or the economic impact of NCDs deliveries. So I would like to put out that we do not charge patients for the deliveries we do. No patient is charged. It is free of charge. The contract is between the Zipline and government of Rwanda. They pay for the service, but no patient is charged. The product that we deliver, the facilities actually do the payment to the suppliers, so there is no monetary exchange anywhere. So I can assure you that the economic implication is very impeccable. And then also, at least when we look at the chain reaction, patients that do not have to travel outside to lengthier hospitals, incurring costs of travel and all that to get quality health care. This time they can just stay in their own district or homes and then get that same quality of care. So that is the economic implication. I hope I answered your questions, and thank you very much for this session.
Thank you very much. Ladies and gentlemen, it's now your turn. I'd like you to rise up on your feet again before the panelists. Please remain seated. Please rise up and stretch up a bit. When you talk about NCDs, just stretch. I don't want you to go back from here and you have a problem. Look up and look down. It helps stress. Look up and look down. Fold your fingers a bit and your toes if you can. Please give a round of applause to the super gentlemen as they take their seats. Thank you very much. As you walk, we are clapping. Let's keep clapping till they take their seats, please. It was nice having you, and thank you. I've picked one thing, that partnership is very key and welcome. You may be seated, please. Thank you for the opportunity. I'd like to welcome the MC, please.
Wow, thank you so much, Caroline, for the energy. We really need to end this conference at this high note. Thank you so much.
Yes, thank you. Another round of applause for Caroline, please. I feel like next time you're coming for my job, because you've done a great job, so thank you. Yes, so we've run really late. We were supposed to end 1 hour ago, but that means that we've had interesting conversations. So I want to take a minute to thank you all for your participation, for the engagement. We want to thank the participants for staying all throughout the day. And of course, we want to thank all the panelists, all the moderators, and all the speakers that went here today for all the interesting conversations that we hope we've learned something. And of course, tomorrow morning as we start the day, there'll be someone to recap and remind us before we start yet again another day of the conference.
Yeah, and I hope we met your expectations you had in the morning. And looking forward to having the second day tomorrow, as we still have a lot to discuss.
Yes, so before we go home, we want to ask you 2 quick favors. One is that we want to take a group photo before the prof heads out. We want to take the group photo with you.
Yes.
Yeah, so we want to take a group
Such
photo.
memorable moments. So we would like to request all speakers to come in front.
Yes.
And our photographers to be ready. Please come forward, our speakers.
Yes, chop chop. Thank you. Afterwards, there's a coffee break available for anyone who wants to grab something before we go. And yes, thank you again for the day.
And the protocol, please help us to tell everyone. The second row, you can come in a group photo, please. Let's hurry.